The brief lunch was supposed to be brief and we had to start at 2 sharp, but the postgraduates haven't joined us. But we will stick to the time and start the next session. We are beginning the session number 3. This will be chaired by Dr. Satyan Parthasarthi, who is the director of Satyan Eye Care Hospital and Glaucoma Foundation, and Dr. Shweta Tripathi, who is a senior consultant at Indira Gandhi Eye Hospital. She's completed her long-term glaucoma fellowship from the prestigious Shankara Nethralaya, Chennai. Over to the chairpersons. My apologies that the students aren't here, but as per the decision of the chairperson, we are not going to go by Indian Standard Time, we are going to go by the scheduled time.
Thank you so much, Dr. Ashwata. I'm really happy to see at least few of you are here. We are really thankful to you. I'm sure that you are also a speaker here, I think. Anyway, I think without much of a delay, it's better we start so that we can have the discussion. Probably people will join after lunch. So you're going to speak as a first speaker? Okay. We have Dr. Manoj Chandra Mathur, sir. He's going to discuss with us on the optic disc, the clinical evaluation. Sir is one of the well-known ophthalmologists from Hyderabad. So he'll just present the topic on optic disc clinical evaluation for 15 minutes, and then we'll have the discussion. So we'll try to delay a little bit for the next speaker, so we'll have more discussions on this. Thank you. Over to you, sir.
So, good afternoon. It is my privilege to be presenting this talk here. I shall be speaking the ABC of glaucoma. The first thing what a practitioner sees or when he or she suspects glaucoma is looking at the optic disc. For a proper disc evaluation, direct ophthalmoscopy is no longer in vogue. You need to have a stereoscopic evaluation with one of these lenses, 60, 78, or 90D lens. What are the basic parameters you need to look out for? Number 1 is the optic disc size. Number 2, the optic cup, neuroretinal rim, any vascular changes, any hemorrhage on the optic disc, any nerve fiber layer defect, and last but not the least, the peripapillary atrophy or the chorioretinal degenerations. The optic disc size, why it is very important. If you see here on the left, you see a small disc with the EyeShala spotlight, it is smaller. The spotlight is about 1.5 millimeters in diameter. Whereas on the right, if you see the disc, it is long, it is a large disc compared to the size of the spot size of the direct ophthalmoscope. The optic disc cup, the vertical optic disc ratio is more important, and then you need to look out for any disc asymmetry. The optic cup asymmetry, also you need to take into consideration the size of the disc, whether there is an anisometropia here. Obviously, the slide on the photograph on the left, the disc is larger than compared to the right. Why it is important to know the cup size, why it is important for this? You see this disc, we know that 1.2 million axons are passing through this disc. If you see this disc, here the cupping is something like 4.4 to 0.5, and the same 1.2 axons pass through the optic disc. If you see this disc, it is a large disc. Here the cupping is about 0.7, but if you see the neuroretinal rim area through this, the same 1.2 million axons pass. If you see all the 3 discs, small, normal, and large disc, what is the lesson that we know? That cup disc ratio varies with the size of the disc. Cup disc ratio on its own is not significant. That means a large cup can be normal for a large disc, a small cup can be abnormal for a small disc. So the importance varies with the disc size. This is precisely the reason why you need to make a conclusive decision as to what is the size of the disc you are looking at, and this is a surrogate for the neuroretinal rim. Next comes the neuroretinal rim, whether it is pink, whether it is pale, whether there is any focal notching. And always you must look out for this axonym, that is the isn't rule, so-called isn't rule, that the inferior neuroretinal rim is thicker than superior, which is thicker than the nasal, and which is thicker than the temporal. So you need to look out for any discrepancy. If the disc is straight, if there is no tilting of the disc, the isn't rule, if it is not followed, then you need to suspect glaucoma. Then comes the important thing, contour versus color cupping. If you see the disc on the left side, like the color cupping may be looking this, but if you look at the right one with the dipping of the vessels in the periphery, that is the real amount of physical amount of contour cupping that you need to take into consideration. The vascular changes, we all know, the nasal shift of the vessels, bearing of the vessels, and the bionetting of the vessels need to be looked at. Optic disc hemorrhages, always rule out a hemorrhage rather than the hemorrhage will not look at you. You say, look at the disc carefully and say that there is no hemorrhage. The nerve fiber layer defect, generally it is seen better with a red-free light. And how does it look? If you see here, a small hemorrhage here, this hemorrhage, now this extends as a dark wedge, touches the disc, base of the disc, and then it fans out into the periphery. How does it look like? With a colored image, the nerve fiber layer defect can be seen here, which is appreciated better here as in the red-free light. The peripapillary atrophy or the chorioretinal degeneration. PPA can be congenital or commonly seen in high myopes. PPA seen de novo or in non-myopic eye should be viewed suspiciously. The peripapillary atrophy, it consists of the central beta zone and the peripheral alpha zone, and very rare nasally or circumferential. So peripapillary atrophy, the alpha zone, it is peripheral to the beta zone and the disc margin. It is irregular hyper or hypopigmentation. It indicates thinning of the RPE, and that can give you a relative scotoma. Whereas in the beta zone, it is central to the alpha zone and the optic disc margin. This is peripheral to the disc margin. It appears as a marked atrophy of RPE. It is a resultant of marked atrophy, and then visible choroidal vessels and sclera can be seen in this zone, and this results in absolute scotoma. The chorioretinal degeneration can give you a general reduction of sensitivity on the Humphrey visual field. Whenever you are looking at the disc, always follow Joe's rules. Until proved otherwise, all discs have glaucomatous changes, all glaucomas have RNFL defect, all glaucomas have disc hemorrhage, and all myopes have glaucoma. Look out carefully for these factors and say no, they don't have glaucomatous changes, they don't have, look out for it and say that there are no RFNL changes, look out and say that there is no hemorrhage, and always suspect glaucoma in myopes and rule it out. So the structural and functional correlation in optic disc evaluation is very important. What I showed you in my first few slides was the size of the optic disc. Here if you see, you are seeing a large optic disc with a 0.75 cupping, but the visual field is absolutely normal. So this is a normal enlarged optic disc with a normal physiological disc. If you see here, I said the isn't rule. The inferior rim should be thicker than the superior, which should be thicker than the temporal, the nasal, and that should be thicker than the temporal. If you see here, there is a notch in the inferior temporal region here that results in the form of an early focal defect in the superior nasal step. Now, if you see this disc here, the inferior neuroretinal limb, especially the contour cup, there is a dipping of the vessel here. It's almost near excavation of the inferior neuroretinal rim, which results in a dense superior arcuate defect. Now, if you see this disc here, there is, if you say color cupping may be 0.7 or 0.75 from this point to this point, but if you see the dipping of the vessels, this is near total cupping, which results in dense diffuse suppression, and then in such cases you need to do a central 10-2 perimetry to mark out the real of the defect and then follow up the patient. Now, if you see this here, the chorioretinal degeneration can have a normal visual field, but there can be a general diffuse suppression in the total deviation plot. If you see this here, always look out for temporal pallor of the optic disc, especially if it is seen in both the eyes. You won't be surprised, you may get a henium-anopic defect. The other eye shows a henium-anopic defect. So with that, like whenever you are sitting in your OP, whenever you are sitting in the thing, what is the first thing? In institutes, the patient gets a visual acuity, patient gets a NCT, then the patient comes to you. NCT, the moment, when do you suspect glaucoma? That is when you make a habit, don't see the disc in your routine with your direct ophthalmoscope. Always make a habit, have a 90 diopter lens with which you can definitely see the disc, even in undilated pupil if you want. First thing that you look at is the disc. The points that I've enumerated, if you follow this basic ABC about disc evaluation, you will pick up the right patient whom you can label as a glaucoma suspect and then subject that patient to further investigation. And the cornerstone of diagnosis of glaucoma ultimately boils down to structural and functional correlation that I have shown in my last few slides. Thank you very much.
Thank you, sir, for the wonderful talk. Before sir leaves for the meeting, I think the PGs, I'm not sure whether your PGs or even completed your PG. Do you have any questions
about disc evaluation?
About
Any
the disc
questions,
evaluation? How many of you really draw the disc in your OPD? Do you really draw the optic disc with the zones? Do you really do that? Okay, so one thing.
Yeah.
Second
You
thing
should
is on, you have explained about the cup, sir.
Yeah.
So would you like to really, tell our PGs what will be the type of cups that we really see in an adult glaucoma versus the pediatric eyes? Usually the pediatric eyes are a little different. One specific thing is like when you're really looking at the concentric cup, that will be very typical of pediatric glaucomas. Adult glaucomas, usually we have the superior notch, inferior notch, and then there is a temporal thinning. All those things you can really see with the RNFL loss. But in a pediatric eyes, it is completely different. You may see that as only a 0.5 CDR with the central cup, but you really may not be able to see a lot of RNFL changes because the RNFL is so thick, even if some is gone, you still may not be able to appreciate how much it is lost. So that is a very typical of adult versus the pediatric glaucomatous changes. Even the juvenile open angle glaucomas, again you will be able to see something similar to that. Concentric enlargement with the RNFL loss, but adult will be having more of a typical superior and inferior loss. But at the same time, sir, to you, when you have a very high IOP, like in angle closure disease, the cup may not be same as the PYAG. So
yeah, naturally, like in angle closure cases, especially in the early part, the onset is acute, and there the disc may appear normal. The disc can be normal. It can be a primary angle closure. We need to address the angle closure issue and stabilize the eye before the cupping real glaucomatous disc changes appear in the optic disc.
So that is very typical of, you will not be able to see a cup that will be very shallow, like 40s and 50s IOP. The cupping will be very shallow, but the disc will have a little bit of a pallor. Pallor in an optic disc, it doesn't mean only it is neurological. It can be glaucomatous also, or it can be a combined glaucomatous and the neurological. So you got to be a little careful. So when you are doing the assessment of glaucoma, you have to make sure that you have the structural as well as the functional changes to be seen. So you do the visual fields and you do the structural analysis like a fundus photography and also the OCT. So it gives you the clue of what is really happening there. It is not enough for you to just understand only the structural changes. Okay, so that will give you, because of the high IOP, the collaterals will disappear on the disc. It is not only the collaterals, the small vessels, because the high pressures, it goes for an ischemic change. So that's why the cup will appear to be very shallow. And also, you might have seen the patient with the large like 0.8, 0.9 CDR. I just want you to, if you can really answer this question. And the patient comes after, say, a couple of months later or say 3 or 4 months later, the cup completely will disappear. Can you say which condition it happens like that? Any one of you? There is a 0.8, 0.9 deep cup, disappears in even a month or 2 months or 3 months. When does that happen? Any idea? Where does the cup gets filled up? So once the cup is getting filled up by the retrograde axoplasmic flow, I'm just giving you the clue, when does that happen? Usually when the IOP is very low, right? When does that low IOP happens? Post-operative. You do the trabeculectomy in a high IOP, especially in younger ones. When the IOP becomes 3 or 4, what happens is the cup gets filled up completely by the retrograde axoplasmic flow. So you will see that absolutely there is no cup. The disc will be completely without any cupping. So you might say, why this patient got operated for glaucoma? So that is very typical. So that is where you need to have the visual fields. So it gives you the clue, okay, this patient had a very advanced cupping. Because of the low IOP, the cup is filled up. So you need to have a fundus photograph before and just before the surgery and prior few visits whenever the patient starts coming in. So that is absolute mandatory that you need to have the fundus photographs. By looking at the disc images, you will be able to understand what is really happening. Is it a neurological damage? Is it just the cup which is corresponding to the glaucomatous changes? Or is it the RNFL? Say for example, you have a superior RNFL loss. Is the superior RNFL loss is glaucomatous or is it non-glaucomatous? Some may be just arising from the disc margin, some may be little away from the disc margin. Those arising from the disc margin with the notch is more so relating to the glaucoma. But if the RNFL loss is little away from the disc margin and you still have an RNFL loss, that is called as a peripheral RNFL loss. That is a very typical of high homocysteine levels, B12 deficiency, Alzheimer's disease, multiple sclerosis, thyroid-related diseases, all these things. So it is important for you, like what Sar was mentioning, looking at the notch, looking at the RNFL loss is extremely important. Take the fundus photographs, like Sar has shown so many photographs with typical RNFL loss. And same way, I want you to understand a small inferior RNFL loss, it may be arising from the disc again, but you really may not have the notch. Those patients are again from a disease called the multiple sclerosis. So these are very, very difficult cases, but you will have to really understand from where these things can come in and how many other diseases that we'll have to keep in our mind. So thank you so much, sir, for your wonderful lecture. So any questions, you just write down anywhere. Thank you, sir. Sir has to go for a meeting. Any other questions, please just write it down. We can really discuss on those factors also, okay? All those questions also. So Sweta, you want to give any comments before you start your talk?
Yes, I'll take this. What about if you say it's a 0.7 cupping, is a 0.7 cupping always a glaucomatous cupping?
Yeah, it's an extremely important question.
Because Sir was beautifully highlighting the importance of neuroretinal rim. So whenever you assess a disc, if it is 0.7 or 0.8, just see the health status of the neuroretinal rim along with the adjoining, as Sir was nicely explaining, the RNFL. Because you have to rule out a condition which is known as a physiological cupping. And especially when it comes to the myopes. Because myopes, they do have a larger disc, a deep cup. So there, you need not put the patient always on glaucoma medications. So always see the rule ISNT along with, always whenever you say no 0.7 or 0.6 or 0.4, whatever, it has to be proportionate. Cup-disc ratio is a proportion which comes. It is never a single entity. 0.7, cupping, glaucoma start, whatever the medication, it could be a normal tension, never like that. Always go with the proper assessment of the NRR. That is really important, and to see the features of those NRR and to see that actually where the cup is there. Also don't go with that I can say the color, the yellowish color of that cup, which you think it's a cup. You see the baby vessels which are emerging out, and that will help you to delineate and demarcate the cup margin. And that's how you detect your cupping. Understood?
Also, in our days, like 90s and 2000, early 2000s, we used to say that once the patient comes with a 0.7 or 0.8 cup, we used to tell the patient you have 70% damage, 80% damage, which is completely a misnomer again. So what you need to understand is 70% cupping may be having a 0 damage to 70% damage. So what you need is, you need to have the structural assessment by the OCT and also by the functional assessment by the visual fields. So the functional assessment by the visual fields gives you an idea how much of the damage the patient really has. Is it neurological or is it glaucomatous? Then we can tell the patient, okay, probably you may have this much of a damage or whatever. So with seeing the cup alone, you should never comment that you have a 70 or 80% damage. That is one thing which you should take home as a message. So thank you so much, Sweta also. Now we have Dr. Sweta Tripathi from Lucknow, from it is not Rajiv, it is Indira Gandhi Memorial Hospital. Okay, it is Indira Gandhi Memorial Hospital. She is the director of glaucoma services over there. She's going to talk on gonioscopy and UBM for angle evaluation. Over to you, Sweta.
Thank you, sir. Thank you, sir, and thank you, AIOS, for giving me this opportunity. So, when we talk about gonioscopy, I'll start with the sentence that this is the best friend in a glaucoma clinic, and I'll conclude my presentation with the same thing, it's a best friend in a glaucoma clinic. So, when we talk about gonioscopy, let's answer a single question, that why do we do this, gonioscopy or UBM? The answer comes immediately that we need to evaluate the angle. Now, why this evaluation of angle is important? Because you need to make a diagnosis correctly to treat a case. Until unless you make a correct diagnosis, you will land up adding the AGMs on the patient's eye, compromising the quality of life, and second, you're not going to achieve the target IOP, which was dealt in the last lecture. Because what will happen when the angles are not open, no matter whatever you do, the pressures are not going to get controlled and your patient is going to get progressed. So now the gonioscopy helps us to evaluate the angle, give us a treatment protocol after making the diagnosis, and for the prognosis of glaucoma, and these are the two means through which we evaluate the angle. The picture on the left side is, everybody knows, it's a gonioscopy being done, and the right side, it's a UBM being done. So before we go in the clinical part, let's have a look over the history. Could be there as a viva question for you, that who was the first person to coin the term gonioscopy? And Trantas is the answer, although Salzman was supposed to be known as the father of gonioscopy. And when we come for the UBM, this was the technique which revolutionized the field of angle evaluation, because after that there was no looking back. It was conceptualized and started in 1990. And then we could have there is a difference between an angle assessment. There's a subjective assessment and objective. So let's understand the difference between two. Subjective is like if person A sees something, person B might not see that thing, and person C might see a thing different. That's subject, sabka alag alag hoega. But for the objective method, there is a clear-cut calculation. So here, this UBM got an edge over a gonioscopy. It gives us the objective assessment, and the core concept was lying only in the oscillating probe of this transducer, which oscillates between 35 to 50 megahertz, sometimes goes up to 100 as well. And this resolution or this frequency gives us the ideal balance of resolution, depth penetration, for seeing the structures. Because when you're visualizing any structure, it has to go to see that which structure you want to see and what is the resolution, what is the magnification of that particular structure that you want to detect any pathology in that. So to note it, you can say that it has got a depth penetration of 5 to 7 millimeters, lateral resolution of 50 microns, and an axial resolution up to 25 microns. So now this is what I was talking about. If you see this, this gives a objective assessment to us. Here, you can see the angle opening distances, you can see the TIA 1, 2, all these things can be measured with UBM, which cannot be done with a gonioscopy. But Always it is a but. So before we go for that but, let's have a look over this gonioscopy technique, that this is how you're supposed to do in your clinics. Put the gonioscope, put the gonio gel, remove any bubbles. There should be no bubble. Now, place the patient correctly with the chin and headrest there. See the light, it's there on the nasal bridge. And still, you ask the patient to look up. Switch off the room light, and there you put the gonioscope. And now you gradually bring the light from the nasal side towards the eye. Now you align your slit lamp, and this is how you visualize your structures of the eye. Now taking out is also really important, because in literature it's described as an optic nerve avulsion has been happened. So ask your patient to squeeze the eye, and then you take out the gonioscope. So with that we go, this was like the patient was sitting comfortably in the OPD. Now this one comes with a supine position, as we know, because it uses, earlier when it was launched, it was using a water bath technique, and the transducer was going in that water bath, and it used to be quite cumbersome. But yes, as the technology evolved, it came out with the help of this is a transient window changing technique, and the other one is a sterile balloon method. Here what it is done is that water is filled into this chamber, and this is placed on a probe like this, watertight closure, and then you place it over the eye, and there you do it. So the technique of doing it is little more friendly, and the patient is going to cooperate with you, and it can be done in a semi-reclining position as well. Now this is the most important part of your presentation today. That's a scan orientation, because here when we go back at this picture, you see there is a white mark. Can you see this white mark? So this white mark is going to decide as to which area you are going to subject your patient for the analysis. So now here what you do is that the probe is placed directly of the area to be examined, in contrast to B scan, where we place it in the opposite pole. Now there are three sections which it basically gives. One is the transverse section, where it gives you images of 6 clock hours. One is the longitudinal, where it gives you a single scan image, and one is the axial scan. Now this axial can be a vertical and a horizontal. When it is a vertical, you place that white mark which you have seen there superiorly, and when it is horizontal, you place it nasally. So that is the catch for UBM. Only if you know the probe orientation, you are going to catch the images correctly. So now the need of angle evaluation, we already know that PACG is leading cause of blindness, but when it comes to the blindness as compared to open angle glaucoma, it is going to cause much greater blindness as compared to glaucoma. Now this is again an important thing. We know open angle, closed angle, at your stage you know everything. But what about beyond closed angle? There is a component in closed angle that is known as a plateau iris configuration, which is really important and needs to be delineated and to specifically treated. Because again, even if you have seen that the angle is closed and you have done a PI, and the PI is patent, but still your pressures are not coming down, that means go back, do the gonioscopy again. And if you've got the, I can say, UBM at your places, you can go ahead and do the UBM. So let's see the structures both way, and I'm just going to take 3 small cases which will help you that how UBM and gonioscopy, they need to be done hand in hand. Neither can be done alone, and you cannot say ki this is done, this is not done. You have to do hand in hand. But gonioscopy is the most important thing. So now here this is a gonioscopy image where you can see the angle structures. See the angle structures. Here when we start, the TM, the scleral spur, the ciliary body, and the iris. So these are the things when you see gonioscopically. And when it comes to UBM, see it is already highlighted here. And when you do the UBM or see the UBM, no, the most important thing is what? To identify the scleral spur. Because when you identify the scleral spur, this is a landmark in a UBM. From here only all the objective assessments, whatever distances we have seen, no, it is calculated. So identifying the scleral spur is really important when it comes to the UBM imaging. So now talking about the different angle closure, where a case was there with a patent PI in the left eye, and the diagnosis was made like status post-acute angle closures, pressures were normal, but when the gonioscopy was done, after performing a PI, that too was visible patent, in the left eye you see it's not opening. It's again quadrant 0 in all the quadrants. So there was something else which was working, though the pressures were under control, but still a UBM was done. Now when you do the UBM, you see the features in the UBM, what is happening. You see that there is obliteration of the sulcus, the anterior rotation of the ciliary body, obliteration of the sulcus, and a kind of flattening of the iris surface. In this picture, it is much more clearer. So this is what? This is what it could be. I have already mentioned. Plateau iris. Plateau iris. Whenever on a UBM you see this kind of obliteration of the ciliary sulcus with a flat iris configuration, you go ahead and make a diagnosis of plateau iris. Now I have put this figure just to show you the difference between a UBM and a ASOCT. ASOCT cannot penetrate beyond the iris, but UBM especially does. So whenever you think that any pathology is there which is lying behind the iris, you go as a correct choice for being the UBM. Now what do you see in gonioscopy? See this pattern? Can you see this? One hump and the other hump. So a double hump pattern is seen on the gonioscopic image. It's not there, sir. It's not there. So this all now I will just run through a little bit fast because time is going to get over. So now the case 2 we are talking about. Again you see that gonioscopically, it's okay. That laser pointer. So what you can do is that here, this was a gonioscopic image, and when the slit lamp examination was done, a bumpy pattern of the iris was seen. And the bumpy pattern was iris was delineated to have these kind of structures lying somewhere in the ciliary body. You can see those cystic spaces are there. So this was a pseudo plateau iris. Something is beneath the iris. It is pushing, but actually it's not the ciliary body, it's a cyst. So it's a pseudo plateau iris syndrome. Now talking about this very important thing which happens in, I can say, the post-glaucoma surgeries, especially when you are dealing with shallow eyes. Now right eye you see trabeculectomy has been done, and in the left eye you see that a patent PI is there. Though the AC looks to be a little shallower in both the eyes. So now we went ahead and did a slit lamp examination where we saw the central AC depth in the right eye, and in the left eye you see it's totally gone. And the right eye, in the right eye it's totally gone in the central area, and in the peripheral area also it's totally opposed. And when you see the left eye, you see little bit is there in the peripheral area, or also in the central area, you can at least some millimeter you can make out. So again something was done, gonioscopy. Saw totally closed angle. This is a 4-mirror image. So totally closed angle all around. And when the UBM was done, if you see clearly here, there is a iris corneal touch, iridocorneal touch is there. It's totally rotation of the ciliary body anteriorly. Forget about the obscuring of the ciliary sulcus. It's totally touching the cornea. And when you see here in this left eye, what I was talking about, a flat surface, obliteration. So now a diagnosis, what do you make in your mind? That's malignant glaucoma in the right eye, and in the left eye it was a plateau iris. And plateau iris eyes are the eyes which are more prone to go into malignant glaucoma. Now this is an eye where you can think of what? Pigment dispersion. See the hyperpigmentation of the angle. So the TM, can you see that? Going up to +4.5. So you have to make a diagnosis, and this is how the UBM helps us in evaluating the distance, because these are the eyes. Can you see that concave peripheral pattern of the iris? And these are the eyes which might benefit with PI, though the role is debatable. Not talking of the nenophthalmic eyes, because you know that the prophylactic sclerotomies are important in these eyes, where you see here, there is a supraciliary effusion. Here is a sclera, and here you see ciliary body. You see there is a supraciliary effusion. If you see this, definitely you are going for a prophylactic sclerotomy in your eyes when you are planning for any kind of surgeries in these eyes. Now this is again, I can say, opaque cornea, showing you this kind of image, Trauma could be manifesting in this way or could be this way. Any difference? These two are traumatic eyes, but this is having a high IOP and this is having a low IOP. Can you see here something? It's a cleft. It's an angle recession, the broadening of the ciliary body, but here there is no broadening, but still it is a traumatic eye and the patient is presented with low IOP. And low IOP but no RD. So that means angle is having a cleft. When you go ahead and did the UBM, you see, there is separation of that ciliary body from that, creating a cleft. So now UBM, you know how helpful it is going to be in making the diagnosis. Congenital glaucoma, we know that it is helpful because majority of the congenital glaucomas are presenting with the opaque corneas. This is very important because these aniridic eyes, they present with Wilms tumors. So these are the life-threatening conditions and they present with opaque corneas. Now post-glaucoma surgeries, I'm done, I'm just winding up. So with that, we talk about the limitations. We know that the gonioscopy needs to be done in a, lighting condition needs to be proper. UBM can be done without that. But yes, to conclude, I can say that they are friends forever. And your best friend in your glaucoma clinic is gonioscopy. Thank you very much.
Thank you, Sweta, for your wonderful lecture and also the wonderful collection of UBM pictures. Wonderful, actually. Thank you. Any questions to Dr. Sweta? She's not going to go away. She's going to be here. So next is, I'll just talk on the visual fields.
Yes, sir. So how do you do, you start your gonioscopies with your 2 mirrors or 4 mirrors? To start with, go with 2 mirrors. Because 4 mirrors, they take a lot of manipulation. And whenever you see, you put the important point in 4 mirrors is that no gonio gel is required. So it is not cumbersome for you and neither for the patient. But start with 2 mirrors. Once you start identifying the angle structures, and your hand stability comes, then you go ahead with the 4 mirrors. So this is the take for gonioscopy to start in your clinics. And with that, we come over to...
Would you like to say which gonio lens that they have to buy? Would you like to say some gonio lenses which they can buy and use it?
Sir, any 2 mirror,
Any
no,
2 mirror.
no conflict of interest.
Okay, so just for the practical reasons, I will just tell you, either you buy a single mirror or a 2 mirror, which we have to use a coupling solution if you really want to see the angle properly. You have the gonioscopes where you don't have to really use the gel, but that is for practical reasons. If you quickly want to see the angle, you can do it. But ideal conditions for a learner, it is better to use the coupling solution and use the gonio lenses. But if you really want to do a documentation, videographs, and uploading your YouTube channels, then you have to buy the gonio lenses, which is used for SLT gonio lenses. That gives you a wide angle view, and also that kind of a view you will never get it in your regular gonio lenses. Only thing is it is a little expensive, but if you really like to document it, save a lot of collections, then you should use that. So thank you so much. You can just keep talking about that. So next 10-15 minutes, I'm going to call at least 1 or 2 PGs for this. It's an interactive session. So visual fields, doing a visual fields in glaucoma becomes mandatory. There is no reason you can say that I'm not going to do the visual fields in this, unless otherwise the patient has a poor vision, there's a media opacities, the patient has a lot of disabilities where he cannot really do the visual fields. Only those patients you have the allowance not to do the visual fields. Otherwise, every patient needs a visual fields in glaucoma for us to stage the disease. Okay, still you're not getting it.
So till then, we'll just revise that what all we have learned so far. So optic disc evaluation, how will you follow that? From where will you start the optic disc evaluation? That was the first lecture, right? We had. Any of you? It's simple, no? You do it in your clinics every day.
I think I'm ready, Shweta. I think you just come back. Okay. All right. So the visual fields becomes mandatory for two reasons. One is for us to understand what is the stage of the disease. Second thing, it is important for us to say whether the patient has a stable disease or is it a progressive disease, for two reasons. We have widely used is the Humphreys visual field machine, and we have the Octopus as well. So I'm just going to touch upon both the instruments here because it is been there for a practice for a very, very long time. So let's see. But you need to have the workflow or interpretation as a proper flow. This is how you should read the visual fields. One is, first is to look at the patient factors like name, age, and whatever other things. Then you have the examination parameters. The second part is it the visual fields? So just go with my adapter. Do you want to try with that? This, you can use it and see. Yeah. Okay, this one.
Most glaucoma clinic. So please, that's my request, that please pay attention to each and every word which is being spoken. Later on, we'll have an open house discussion also.
So it is connected to your system.
So any idea, like you have finished your residentship, or you are like first year, second years, what? First row.
Okay.
What? First year, second year, third year? Second years. So how many like visual fields, you know any idea about visual fields you have? How many types of visual fields are there? Two, right. Come up with that. Two. What is that? Octopus, and the other one, sir just said, no? Octopus, and the other one? Humphreys. Have you used Humphreys? Okay. So before we start any visual field analysis, as sir had just started in his discussion, that pointing out the patient's age, the date of examination, the pupillary dimension, and also I'm sure that sir is going to cover all these points, but just briefing you with that without the presentation right now. So these are very important points. Why the date of birth is really important in visual field? Because the machine has got a data setup, and with which it compares your patient's data, and then it gives that how much points have been depressed. Understood? So that is why, so okay, we are back with the presentation.
I'm really sorry about that. So what you need is, you need to see, is it a trustworthy visual fields that you are reading, or you just want to discard it? Then how much the patient has the visual field loss. In general, as a local defect, a general defect, then you have to see how much is the local defect. Then again you see if the local defect is there, is it really a glaucomatous defect or is it something else, a neurological or local defect? Then if it is only the glaucoma defect, then you see whether it is structurally correlating with the defect which is there. You look at the polar graph. The polar and the cluster graphs are available only in the Octopus visual fields. Then of course you look at the severity of the disease, how much it is there. So this is the typical Humphrey visual fields, but this is the Octopus machine. But the printout, you can get it as a Humphrey printout. That is one advantage with the Octopus machine. I don't have any financials with them. So the first, there are 8 zones. I have divided as 8 zones in Octopus as well as in the Humphreys. The zone 1 is the general information. Always look at the patient's date of birth is whether correctly mentioned or not. Then you see that whether age is being mentioned properly or not. Sometimes the time of the test also matters a lot, because the afternoons when you do the test may not be really good. The patient may be feeling very sleepy. Then you have the other parameters like what is the fixation target. Some patients may have a poor fixation, so you may have to go for a parafoveal fixation. Then you have the fixation monitor that is available only for the Humphreys. Octopus, it is not really required. Then you have the stimulus size that is either 3 or 5. You go with 5 only in case of where the vision is poor. Then the background is always fixed. Then you have the strategy. In Octopus, we use a G dynamic. In Humphreys, we use a CETA fast or CETA standard is a normally used one. Sometimes they use a CETA standard as well. The pupillary diameter becomes very extremely important. If it is less than 3 and more than 6, both becomes a difficult thing to assess the visual fields. Then you have to always mention the visual acuity as 6.6, 6.12 or whatever the vision. Why it is important is when you have a 6.6 vision, and if your foveal threshold shows only 10 decibels, then it means there is something wrong is going on. Then you have how much is the refractive error the patient has. This is very important. Every part has its own importance. The second zone is the reliability indices. All of you know what is the fixation losses. Then you will have to see that. Then you have the numerical, the threshold values. Whatever the sensitivity is measured, that is calculated in the numerical data, that is shown as a grayscale. That is the typical of Humphreys. I will show you the difference. Then you have the total deviation, then you have the pattern deviation. Total deviation is inclusive of all, diffuse as well as the local defect. Pattern standard deviation is only the localized defect which is relating to glaucoma. The same thing is shown in the probability plots varying from 5% to 0.5%, and you have the global indices which tells us about how the severity is. Only based on this we are going to fix up the target pressures once everything is okay. So this is a typical Octopus printout. We have a 8-in-1 or 9-in-1 printouts in the Octopus. Whether you have a 300, 600 or 900, any of the machines, you'll have this. So I'll show you the differences in this. The first one is the Humphreys, second one is the Octopus. The threshold values are same as values in the Octopus. The grayscale in the Humphreys is little different from the grayscale of Octopus. The grayscale of Octopus is basically taken from the total deviation plot of something similar to the Humphreys. So it is precisely what it means for the age-corrected values. Then you have the total deviation plots of Humphrey, which is comparison to the comparison of the Octopus. Then you have the pattern standard deviation as called as a corrected comparisons. Then you have the probability plots called as a probabilities, directly called as a probabilities. In this, it is called as a total deviation probability. Then you have the PSD probability. So it is called as a probabilities and corrected probabilities. Then you have the mean deviation in Humphreys, that is called as a mean defect. Then you have the PSD, that is called as a SLV, that is a square root of loss variance. We can discuss this a little later. And you have the glaucoma hemifield test. In this, it is little different. That is coming under the defect curve that is called as a Baby's curve. Then you have the visual field index, but that is again different. Then you have the fixation losses, but what is this fixation losses is little different in the Octopus is, it gives us out of 8 questions asked, the patient has answered 1 as a wrong. So it comes as a percentage values. But in Humphreys, it comes directly as a percentage values. Then the fixation losses and gaze tracker, both will not be available in the Octopus because the machine automatically adjusts. The moment the patient takes out the head, the Octopus will not do the test anymore. So that is very typical of Octopus test. So this is the Baby's curve, which gives you the details about how much is the local defect and how much is the diffuse loss in the patient. So I'll just give you an example of 1 or 2 patients here. So anybody wants to volunteer here? Any one of you? Can come, I will not say anything. If any of you want to volunteer. Dr. Ashwati wants to, yeah, please, if anyone can. If you know about the Octopus, you can read the Octopus. If you know only the Humphreys, I'm giving you the pattern of Humphreys. This is an interactive session. There is no point in me just keep talking about all the time. So anyone?
One of you could volunteer and come here. This is not your real YYOC.
Just make some mistakes, whatever. I'm really happy about that. Just read only the zone 1. Any one of you can read. Is there anything wrong in the zone 1? So always go with only a methodical flow. Many of us as an Indian, we never do that. We just go directly, only see the grayscale, and we see the PSD values and say, okay, this is mild disease, moderate disease, or severe disease. Quickly, any one of you want to say about the zone 1?
We'll start here. Anything you want to say, like,
Anything,
yeah.
everything correct or anything wrong in that? Just a quick thing. I hope you can see that.
It's the visual field analysis of a 55-year-old patient
Wonderful, yeah.
with the pupillary diameter of 4.2
Okay.
millimeters.
That is exactly I was telling. Never jump from one end to the other end. Always go with the methodical order. Age is 55 years.
Taken on 25th.
The timing of the day is reasonably okay. Then you come to the fixation, whether it is a central point of fixation or is it a
It's
parafocal
central point of
central
fixation.
point of fixation. Then you have the stimulus is 3. 3 is fair enough. Then you have the strategy, but in this is a G dynamic that is in the octopus. But usually what else you have? You have, what is the Humphreys pattern? It is a zeta?
Zeta.
Zeta? Zeta
Zeta
standard,
standard.
which is comparison to the G dynamic. Okay, then is the pupillary diameter okay?
Yes, sir.
So what is
More
the
than
normal range you wish to have?
3 to 6, between 3
in
to
between 3 to 6 is fair enough, that is okay. Then visual acuity is not mentioned. So is it right thing for you to read this chart or not? It is okay because you will have the data somewhere else.
Okay, sir.
But you have to understand, once you have the visual acuity 6.6, if the foveal threshold values are very less, then it is important. There is something wrong is going on, okay? Then you have the glass powers have been mentioned properly. Okay, so that is zone 1. Zone 2, anybody wants to comment? Quick thing.
Yes, sir. Zone 2,
Wonderful.
false positive error rate of 14%, false negative error rate of 0%.
I just want to
Fixation
show you that
losses,
same thing.
there are no fixation losses noted.
Yeah. I just want you to see the same thing in the zone 1 and 2 in the bottom. This is the octopus. If you really see that, that is called as a catch trial. I thought you don't have a power. Your father has put in a good lens for you.
Yes, sir. One out of 7.
Yeah, so that is coming as a 14%. And 8, 0 and 8. So that is 0%. So that is called as a catch trials in the octopus. It is not that difficult. So I'll just, go back to this one. The zone 3. See, even if you read only one chart, I'm okay because the rest of it is the same. 3 and 4. So what is 3?
Total deviation.
That is a values, threshold values. Whatever the patient sees, he presses the button. So that is the threshold values, whatever the sensitivity. Retinal sensitivity in each location is called as the threshold values. Okay, that is the threshold values. And on the side, the 4 is the grayscale. So this is not age matched. It is just whatever the patient presses, it comes, okay? Then you have anybody else to volunteer for the zone 5? Quick. Zone 5. So zone 5 is the total deviation, but I want you to see this. Zone 5 is, and zone 6 you see some minus values in this. Okay, that is how much it is deviated from the normals. But in the octopus, if you see, it will not show as any minus values. Octopus, the deviations will be shown as only in the plus values. And if it is less than 5 decibel loss, it will not show any values. It will show only a plus. There is some change, but the values are less than 5 decibels. So that is what it indicates. Then you have the probabilities here. Is there any defect which you see here in the probability score? There is no change. And in the zone 8, the mean defect is only 1.4 and the PSD is 1.9, which is fine. So, but we should never relate this to only looking at this and you can say normal, but you have to always correlate with the fundus photograph. So this fundus photo shows any defect in this? There's absolutely no defect. but this patient came out as a toxic optic neuropathy by looking at only in the OCT. Okay, that is called as a temple sign, that we can discuss it later. So that is why I'm saying having done only one test, coming to some conclusion is not good enough. So I'll just go through another one more. You can see there, so with all the parameters, I'll just go through a very quickly one. You can see the scotoma in the central 10 degrees area. Can you see that? Yes, scotoma in the probability plot you can see in the central 10 degrees. So what is that you see is a small defect in the inferior RNFL area. I want you to just understand this, and then I'll show you this in the black and white picture. Again, it picks up beautifully. So what is the importance is, I want you to see this photograph again. Carefully you see the RNFL defect, which is very close to the central papillomacular bundle. Any defect which is close to the central papillomacular bundle with the normal IOP values, it is called as a NTG pattern. So once you see this central defect which is close to the macula, that is called as a NTG pattern. So you can read this chart very carefully one by one, then you can really understand, is it you are discussing the POAG, PACG, neurological or NTG, all these things can be really picked up. So we can discuss more and more. As I think the time is just running out, we can discuss more after some time once we have the discussion time. Thank you so much.
Thank you, sir, indeed, for beautifully eliciting out the important features in field evaluation. With that, we move on to our next speaker, that's Dr. Partho Pratim Dutt Majumdar. And he's going to tell us about the evaluation of a patient with uveitis. So all to you, Dr. Partho.
Thanks. Can I have slides? So, good afternoon, friends. So, I'll be talking to you on evaluation of a case of uveitis. So, when we think about evaluating a patient of uveitis, we are primarily, we can divide it into three categories. Like in first, we just try to evaluate the anterior segment. We have slit lamp. Then as you, I think Shweta has showed you how to do a gonioscopy, and you need to do check the intraocular pressure also. So in second category, we just shift to the posterior segment, where we try to see that what is there in fundus, what is the clinical fundus looks like, and then we take help of various imaging techniques. And then broadly, because we are ophthalmologists, we have a different set kind of OPD. So we try to evaluate the various system, but here we try to take the help of history. We try to take various kind of history and try to see that whether the other systems are involved or not. Now, when we read our textbook and we have a conception that the patient comes to us, we take a history and then starts doing the clinical examination, then go to imaging, then we order laboratory investigations, and then finally we advise the patient treatment. But it's not the case. So what ideally we should do, we should greet our patient, just ask about the symptomatology, what are the presenting symptoms, then we do a clinical examination, and then we should start taking the history based on the clinical examination. Then we can do imaging, and if there is any relevant findings we can notice, then again we should revisit our history. And then we do a laboratory investigation, and then again the history is not over, then again we should take the history, and then finally we give the patient treatment. So, and all this should be done taking care of that systemic examination, which I'll be discussing in later slides. So now I always tell that the microscopy remains the mainstay in uveitis management. So no, not this microscope. I'm talking about this microscope, which we are the unique person in medicine who can see the inflammatory cells, who can visualize the inflammation under microscope, and we can categorize the inflammation. Think about the rheumatologists, they can't think about inflammation, they can't see inflammation. For them, if they want to see the inflammation, they need to do a biopsy. send that biopsy specimen to a pathologist, and who will tell them that whether there is inflammation or not. But unlike rheumatologists, we ophthalmologists, we can examine a patient. We can see the inflammatory cells, like we can see a lymphocyte, we can see a macrophage, and we can decide that how much is the inflammation. So just try to use this microscope. And when you start evaluating a patient, always try to decode the inflammation by dividing broadly into granulomatous and non-granulomatous uveitis. So all of you know that this classification is very ancient classification, also known as Wood's classification. The downside of this classification is that sometimes some entity, for example, the ocular sarcoidosis, it can start with granulomatous uveitis and again can present with non-granulomatous. But for beginning, this is the ideal classification to categorize the inflammation, and you can actually decide on your further course of action based on this classification. Now, as a postgraduate student, when you examine a patient in slit lamp in your outpatient department, then three things I want to highlight. One, the number one is rheostat. So sometimes what happens, you turn the rheostat very bright, thinking that you want to see the patient properly, and the patient is extremely photophobic and patient can't tolerate that. So immediately you turn down your rheostat, so your illumination comes down. Now here what happens, if there is 3+ cells, you will never miss it. You will try to, eventually you will find that there is 3+ inflammation there. But if it is a 1+ cells or occasional cells, then you may miss this clinical picture. Because if your rheostat is down, then you may not see it properly. And you have to do this because the patient is photophobic, so you can't turn your rheostat up. So what you should do here, instead of using a broad slit lamp beam which will cause the patient photophobia, you should reduce the width of the beam and use a narrow slit beam with full intensity of light. Remember, you should not reduce the intensity of the light, rather the width of the beam. So that's how the patient, you can avoid the photophobia, and you can examine the patient and avoid missing the 1+ cells. Now the second problem you face in your clinic is that, is it a pigment or cells? Because when we use phenylephrine, the phenylephrine is notorious to cause pigment release from the iris, and sometimes this iris may give you an impression that you are dealing with a case of anterior uveitis. But if you see there the inflammatory cells are relatively large, and the interparticle distance between them is more. And whereas if you see the pigments, they are brown, dark brown in color, and they are very sparse, very closely arranged, and the density will be much more than the inflammatory cells. Now, another important point I just want to highlight here is that the dilatation. So now you have to remember that always examine the patient before dilatation, because certain feature, for example, iris nodules, the pattern of the iris, and the before gonioscopy also you have to do. Now the iris pattern, if you see there are certain uveitic entity. For example, all of you read in Western textbook, it is heterochromic iridocyclitis, Fuchs heterochromic iridocyclitis. But in Indian patients, the heterochromia is very difficult to notice. It is so subtle that you may miss that. So for that, you have to look at the iris pattern, how the pattern of the iris is, and based on that, if there is blurring of the crypts, the fine pattern is lost, then only you can diagnose that. So similarly, the iris nodule, you can see here the first picture. It's not picture. The first picture, you can see it is in dilated state, and you can't appreciate the iris nodules, the Copp's nodules. Where is the same photograph, same patient in undilated state, you can see you can appreciate the Copp's nodule. Now, coming to a case, anterior uveitis, a 26-year-old history of recurrent attacks of redness, ocular pain, and blurring of vision in left eye. Now, how will you proceed? Now, if you try to decode that, you take a meticulous history and try to apply the Wood's classification. And here you can find out that the codes take you are sure that it is an anterior uveitis, and then try to see that what is the laterality of that inflammation, and is there any specific clinical signs. Now you know that it is already a recurrent attack, and it is unilateral because only left eye is involved. Now you see here again what is happening. So now, when we are talking about the recurrent and unilateral, then the three causes are very important. One is HLA-B27 associated uveitis, one is Fuchs uveitis, and one is viral uveitis. Now see how we can decode this. Now HLA-B27 associated is alternating bilateral. That means the patient will come to you and will give a history that yes, there is history of recurrent attack of redness, but sometimes it will come to right eye and sometimes it will come to left eye. So we call it that ping pong uveitis. It will go to one eye and then again it will jump to other eye. So that's why it is bilateral, and the inflammatory material, if you examine, there will be fibrinous exudate. Now coming to the next variety is the Fuchs uveitis. Now Fuchs uveitis is almost always unilateral, but yes, there are certain cases it can be bilateral also. So as a rule, it is unilateral, and you have to look that carefully the iris pattern. If there is, you can see here the blurring of the iris crypt. So these are the diagnostic actually features of the Fuchs uveitis. And also another, the typical keratic precipitates, that the stellate capes. So stellate capes can be seen in Fuchs uveitis. Another important point you have to understand about that is that you know that all the keratic precipitates are arranged in a base down triangle, which is known as Earl's triangle. So there are two entities where the Fuchs, the keratic precipitate will cross the midline and it will involve the entire corneal endothelium diffusely. So there are two causes. One is your Fuchs uveitis, second is the viral uveitis. So now when we are decoding the viral uveitis, what all you have to see? You have to pay attention to the corneal signs, try to see the corneal sensation in exam. This is very important because sometimes the examiner may ask you that have you checked the corneal sensation. The second is that you have to see the corneal opposites, whether there is any corneal edema or Decimet's folds are there. And obviously all of you know that the viral uveitis is notorious to have a secondary rise of intraocular pressure also. So you can see that. Now coming to that keratic precipitate, I told that the Fuchs and viral uveitis will have diffuse distribution of keratic precipitate. Now another thing you see is that the pigmented keratic precipitate. So it is very characteristic of the viral uveitis, and also sometimes they may have a mutton fat capes also. So these are the point in favor of this. And the second thing is that the iris atrophy. If you see here, the two things you can notice in viral uveitis. One is you can see that without any dilatation drop, you can see the shape of the pupil. Sometimes it is called D-shaped pupil. Why it happens? Because there is destruction of the pupillary raft by the viral viruses. And also sometimes you can see the patchy iris pattern here, as you can see here. This happens because the viruses, particularly the herpetic viruses, they causes the endarteritis and causing the necrotic patches in the iris atrophy. Now, sometimes you can see a corneal opacity and you can tell us the diagnosis, like in this case, you can see here the coin-shaped opacity. So this is very common in CMV retinitis. You can see the coin-shaped corneal opacity and you can see the pigmented capes. So this can be seen in cytomegalovirus anterior uveitis. Now, always you have to remember one thing, that dilated fundus examination is must in all cases of anterior uveitis. For example, you see this patient with anterior uveitis, and if you do the direct ophthalmoscopy, as many of you are only examining the patient with direct ophthalmoscopy, and if you see, this is the view you'll get. But if you dilate this patient and try to examine the periphery with a indirect, you can see that this is this. So this was not a case of anterior uveitis. What was that? Anyone? Any postgraduates? This is acute retinal necrosis. So the acute retinal necrosis you can miss if you are not examining the periphery, and if you only try to decode it only by your slit lamp examination, you will diagnose it as an anterior uveitis. So the indirect ophthalmoscopy is must. The second thing, for example, here, a 30-year-old male with diminution of vision, and there is a history of fever 10 days back. Can you tell me your diagnosis? Anyone? What kind of uveitis is this? So as a postgraduate, it's very important that you have to differentiate between the retinitis and choroiditis. So I'll just make it little simple for you. There are a lot of colors and morphology, but remember one thing, always try to trace the retinal vessels. It will lead to diagnosis. Because if you see here, what happens here, in cases of choroiditis, the lesion is here and the blood vessel is here. So is here, you can see the choroiditis lesion and you can see the blood vessels here. So if you can see this kind of picture, then it is choroiditis. And similarly, if you can't see the blood vessels like here obscured, you can see here the retinitis lesion is here and your blood vessel is here. So then it is a case of retinitis. Clear? So now, the second thing you have to remember when you are dealing with a case of retinitis is almost always infectious. So only two conditions you will remember where the retinitis can be there and it is not infectious. Number one is Behçet disease, where you can see this kind of retinal pigment, retinal infiltrates. So in Behçet disease, what you have to take history? You have to take the history of genital ulcer and oral ulcer if you see this kind of infiltrates. The second is if you see this kind of cream colored multifocal subretinal pigments and in an elderly patient, then you have to suspect the diagnosis of intraocular lymphoma. So what you have to do, elderly patients, you have to do a CNS imaging, you may have to do a vitreous biopsy to take the sample for cytology and mutation, and you have to consult a ocular oncologist. Now, how to evaluate a case of retinitis? The common three scenario in our clinical practice is number one, viral etiology. Second, it can be syphilis, and third, it can be toxoplasma also. There are several causes of viral retinitis. I'm not going into detail. Just to give an idea about suspect syphilis, if you see this kind of ground glass appearance. Now, what is ground glass appearance? You can see here. This is you can see the small creamy white superficial retinal precipitates. But here you can see this is called the ground glass appearance because you can see the underlying retina. Okay. So now in contrast to that, if you see that, sorry. Yeah. So in contrast to that herpetic retinitis, the herpetic retinitis, it will be, I'll just take 5 minutes and run. So herpetic retinitis, it will be fully opacified retina, whereas in syphilitic retinitis, you can see the underlying. So now coming as a postgraduate, this table is very important, like how to differentiate between HSV, VZV and CMV. So CMV primarily is seen in immunocompromised patients, and if you see the mode of transmission, CMV occurs through the blood, it is mainly the vasocentric lesions you can see, whereas in HSV, VZV, it starts from the periphery, a pattern that corresponds to the termini of the ganglion cells of the nerve fiber layer. And the HSV and VZV replicates very fast. If you are not starting the treatment, it will finish off the entire retina in maybe in 3 to 4 days. Whereas the CMV, the replication rate is very slow and it will take a longer time to involve the fundus. Now, suspect ARN, already I have showed you. Now, this is coming to little bit about the choroiditis. When you are looking for the choroiditis, you have to understand that there are two variety you need to know. One is serpiginous choroiditis, one is serpiginous-like choroiditis. Now, what is serpiginous-like choroiditis? You can see that geographical patch-like pattern here, and you need to differentiate between these two. Serpiginous-like choroiditis means that the secondary pathology is infection. For example, in India, the most common cause is tuberculosis, whereas the serpiginous choroiditis, the classic serpiginous choroiditis is autoimmune, and the classic treatment is through the immunosuppressive and pulse corticosteroid. Then multiple choroidal tubercles you can see in various like tuberculosis and sarcoidosis. And then Dehlen-Fuchs nodules, you have to see there may be various nodules in the periphery of the fundus. And always you remember, when you think about laboratory investigation, there are certain conditions, there is no need to order any investigations. Without laboratory investigation, you can diagnose. The one is that infectious etiology like acute retinal necrosis, CMV and toxoplasma. You see the clinical phenotype of the lesions and you can make a diagnosis. For example, I'll give you a picture. Do you need any laboratory test to diagnose it? No, you can clearly tell that it is a toxoplasma retinochoroiditis. So similarly, sometimes you have to pay attention to some clinical signs, like there is a healed lesion where adjacent to the lesions there is a active retinochoroiditis, then you can make out. Then sometimes you can see this kind of pattern, like these are called Chilaris arteritis. So these are very common in toxoplasma. So coming to the retinal vasculitis, you have to differentiate that the certain retinal vasculitis predominantly involves the vein, like sarcoidosis, toxoplasmosis, Eales disease, and HIV. And you have to suspect the tubercular retinal vasculitis if you see this kind of retinochoroidal chorioretinal patches around the blood vessels, then it is a characteristic sign of the tubercular retinal vasculitis. So just I'll finish with this slide. So any postgraduate, can you decode here? I am just showing you jigsaw puzzle with two clinical disease, clinical entity. Can you tell me the two diseases? Yes, louder. Yeah. Vikage, correct. Another? Behçet. So see, now if you go into that, so you correctly diagnosed it a Vikage and it's a Behçet, right? Now I'll tell you the secret behind that, how you diagnose. I have shown you 3 ophthalmic signs and I have given you 5 systemic signs. But still you are an ophthalmologist, you could diagnose that. So that means that you have to pay attention to the systemic signs. Sometimes you can decode your diagnosis just looking at the systemic signs also. So always try to do that. To conclude, you have to remember that how to present a case of uveitis in examination. The number 1 is you have to diagnose the anatomical site of inflammation. Next, you have to find out whether it's a bilateral or unilateral. Number C, whether the course is chronic or acute, and you have to document. Now, when I talk about the documentation, that is very important for the post-graduation. Let's see how to do that. For example, I'm showing you these slides. This is very important in examination. If you are documenting a case of uveitis, remember one thing: you have to mention about the hypopyon. Even if there is no hypopyon, you have to mention that there is no hypopyon. This is mandatory to diagnose a case of anterior uveitis. And also, if you are documenting the hypopyon, you have to write the height of the hypopyon, that how much it is, 1 millimeter or 1.5 millimeter. So that is mandatory. So again, coming to that iris nodules, you have to mention this exactly where it is mentioned. So similarly, just last slide of this. Yes, just last slide of this. You have to document it properly. The clock hour you have to mention where the retinitis lesion is, where exactly the retinal vessel is involved, and you have to follow the color coding for that. Thank you.
Thank you, Dr. Partho, for your nice presentation in details. Like, I have one question. In your clinic, what is your, are you seeing more syphilitic uveitis patient nowadays? Vis-a-vis?
Yeah, definitely. Syphilis is very common nowadays, and the problem is that we were taught that you should always take history of high-risk behavior and all, and I think we have gone beyond that. So any patient, the Sun classification now says that any uveitis you are seeing, ideally you should rule out syphilis. There is no question of high-risk behavior or going into asking the patient about that and then ordering syphilis. If you are examining a case of any kind of posterior uveitis, even the scleritis also, it is mandatory to rule out syphilis in these cases.
Thank you. Any question? So I'm going to invite Dr. Mohit Dogra. He will talk about indirect ophthalmoscopy, retinal drawing, and fundus photography.
Thank you, sir. And Dr. Majumdar is always a tough act to follow, but I'll try and do whatever I can say. And I think it was just a perfect kind of prelude into my talk when he finished with the retinal diagram of how to represent intraocular infections. Part of that will be covered in what I will show. I'm not going to be speaking on indirect ophthalmoscopy or fundus photography. It's just going to majorly be on retinal drawing and how to correctly kind of demarcate and show and actually highlight different things. That's the Amsler-Dubois cartogram. Anybody wants to quickly show those 3 concentric rings, what they stand for? The innermost ring is for anybody, just is the innermost ring the aura? The equator. The middle ring would be the aura, and what about the third ring then? Pars. So it has to be a junction, right? Ora is a line, equator is a line, pars plana is a structure. So it can't be demarcated by a line. It has to be a junction of two things, right? So it's a junction of the pars plana and the pars plicator. So it has to be a line, right? And why would you want to show that? I mean, most of your retinal drawing should finish at the ora. What's there to see, or why should we be interested anterior to the ora? Anybody? Vitreous base, you've heard of the vitreous base. It'll straddle the ora. It has connections anteriorly. You have certain, uveal issues, uveal pathologies that might arise from that area. You could get ciliocoroidal detachments secondary to certain retinal pathologies. So all of those will be seen there. You could have microcystoid degenerations and other things, and you might want to show them there. So hence these three, just the basis, the innermost circle, the middle circle, and the outermost circle, right? And the bang center is not the center of the universe, so it's not the center of the optic disc. The optic disc is to one side, and typically it will be to one side, which will correlate with the clock hour, which is 11 up top and 7 at the bottom. The center will be the fovea, hence you will have asymmetric distances. So from the disc all the way up to the periphery, about 23, 24 millimeters, and from the disc all the way to the ora nasally would be about 18, 18.5. So the center is not the optic disc, the center is the fovea. And depending on whether you are representing the right or the left eye, the disc will be on either this or the other side of it. This is just indirect ophthalmoscopy, and as I said, I'm going to skip that. I'm just going to look at, how to represent once you've, seen what you saw, how do you adequately and accurately represent it, so that even if there is someone who did not see the patient, if they were just to go through the chart, or if you were to try and explain to them, they would have the same picture as to what you saw. So retinal detachment, we're going to just start off from there and look at different things, because it's going to cover different aspects of the retinal drawing. So you want to look at the optic disc, the fovea, the retinal vessels. You want to look at the extent of the retinal detachment, identify the breaks, the clock hours, the position, PVR changes if they are there, and represent them adequately, choroidal detachment if there is there or not. So that's actually showing fairly well. That's a pseudo-color ultra-wide field optos photo. You can see a fovea involving inferior retinal detachment. And that is the same patient, just a more decentered photo, and I think you can see the break right there. And that is a representation, your Amsler-Dubois cartogram, just to show that white thing is just to de-identify the patient. And the idea is that anytime you want to try and reproduce something at any forum, please try and de-identify the patient and not have patient names, age, sex, and other demographic details. So, I think all of you know detached retina is blue, light blue. The outline of the retinal break is a darker shade. The retinal break per se is red, and then that will actually tell you what is going on and what is not. So no PVR apparent, no PVR shown, no choroidal detachment, and single break. So this is one of the most simpler, straightforward representations. But you actually have to see as to where the extent is, where the break is. You can't make that break, inside the first line, because you can see on the centered ultra-wide field image and the inferiorly decentered image that break is just outside of what you would say is the equator. So it has to be adequately represented, because the management then, of course, depends on that, whether you want to buckle this or not. Another photo, and if you can see right there is a horseshoe tear, if it's actually visible, and that is actually shown as so. Simple, no retinal detachment, the entire retina is in a light shade of red, and you can see that the outline of the horseshoe tear, along with the localization and where it exactly is actually shown there. This is actually pretty anterior, almost, I'd say, if you were to look at the equator and the ora, this is actually more towards the ora, hence has been shown there. And these are simpler things to kind of show. This is, this now has a bit more of a retinal findings to it. So retinal detachment, you can see that big break inferiorly. You can also see a lattice, so you can see all of those things. So a total retinal detachment, albeit shallow. You can see a lattice, which is that thing which is upper temporal there, and you can see the location. It is between the equator and the ora, and there's this large break, which is again shaped as so. So no PVR changes that you could see, so none have been shown per se. This patient now has a choroidal detachment. You can see that there is, a scleral buckle is in place, a rather high posterior buckle, and you can see that there is a choroidal detachment nasally. So you have to show the presence of a buckle in the diagram. You have to show the presence of choroidal detachment in the diagram, and so that's what you have. You have that brown big thing, which is nasally, which is the choroidal detachment. You have the buckle, which is that shaded, almost like a spoke wheel pattern going all across, which is the area where the tire is, and that's actually seen there. And the band is that narrower thatched thing that you can see, which is actually right there. And these are certain other things that you might want to show, but we're basically going to come to this. So you have 5 or 6 different colors. If you have a blue solid color, which is I think the most commonly used, it's typically used to signify detached retina, retinal veins, outside of outlines of retinal breaks, outlines of the ora serrata, meridional, radial, or fixed retinal folds, outline of flat neovascularization, very seldom used, but that is what it typically should be used for. Outlines of retinal of lattice degeneration with that thatched X kind of appearance, outlines of thin areas of the retina and intraretinal cysts, as has been shown in the image right next door. This is also, as you can see there, so the breaks, the outlines have to be blue, the center of the break has to be red. You can see retinoschisis. I was asked by someone, so right there is how you would want to show retinoschisis. It's almost like lattice, except you don't make thatches, you just make arrows pointing one side, and if you have 2 layers of your retinoschisis, then the inner layer is angled one side and the outer layer is angled the other side. Now, how you see both on top of each other beats me, but that's what's written, because once you make in a diagram, one layer that way and the other layer that way, it almost looks like a lattice, but that's what it said, right? And then you come down to red, which I think is, along with blue, the most commonly used color. Retinal arterioles, neovascularization, vascular anomalies, vortex vein, attached retina, hemorrhages, pre-retinal and intraretinal. Interior of retinal breaks, which we have seen, interior of outer or inner layer holes in retinoschisis, and you can see a representation of all of those things, in that corresponding diagram. Then you come down to green, which is also fairly commonly used. This could be solid, or this could be stippled or dotted with kind of a broken appearance. So one quick thumb rule is that anything in the vitreous which is not meant to be there, which is either degenerative or secondary to pathology, is green. So your vitreous haze, your vitreous hemorrhage, your posterior vitreous detachment, your snowballs, your snow banking, anything in the vitreous is green. So when in doubt, if it's in the vitreous, please make it green. Anything within the retina, or pertaining to the retina, for the most part is blue. Anything in the subretinal space, not on the choroid, is yellow, and anything in the choroid is brown. So if you know this, I think for the most part you have 80–85% of your things as far as the retinal diagram is concerned, that's actually sorted. And then you come down to a black solid, which is again not that commonly used. So typically used to signify pigmented, kind of things that you see in the fundus. Could be old cryo marks or old laser marks, could just be demarcation lines that you see in chronic retinal detachments, or other hyperpigmented areas or lesions that you might see, your congenital hypertrophy of the retinal pigment epithelium, Grupcher, P, or solitary, or whatever. Generally not commonly used, but anything which is pigmented will actually be shown by black. One of the lesser commonly used colors to signify structures in retinal diagrams. Yellow solid is important if you want to do, I think is used a lot more commonly and a lot more frequently when you want to try and signify posterior uveitis, because active retinitis is yellow, active choroiditis is yellow. It depends on the differentiating thing is that because the choroid has a lobular anatomy, you try and draw the active choroiditis in more of a amoeboid yellow pattern and not disjointed. Of course, you can have multiple ones, but each of them will be amoeboid because of the lobular architecture of the choroid. The retinitis will be either one continuum or will have different areas like that, like stripes. So yellow, the color is the same. The depiction of retinitis choroiditis is actually different. And there was a brown there. I think we actually glossed over brown, which is the second last slide, actually. So anything in the uvea. So typically, your three most common things that you would highlight or show in brown are your choroidal masses, melanomas, metastasis, or any other masses. Your healed choroiditis, so active choroiditis is yellow. The healed choroiditis will be brown, and it will also show your tires and buckles if they are in place, if you're speaking particularly for post-operative eyes of retinal detachment. And for all of this and more, I think this, there's a pretty good article, a review article by, in the IJO, I think late 2022. It gives great pictorial representation of both anterior segment and posterior segment color coding. I think if you go through that, just look at the photos that the author has shown. They are self-explanatory. They tend to cover most things. And with that, I'm happy to take any questions if there are any. Thank you.
Nice presentation, Dr. Dogra. I want to ask you one thing, very simple thing. For the young ophthalmologist, what is your suggestion? Like in the era of wide field photography and ultra wide field fundus photography, what is if the young ophthalmologists are whether they will lose the interest in doing in-depth ophthalmoscopy and just to get rid of their back pain or not?
So I think that it's a two-part answer, sir. Whether they lose interest, I think yes. Whether they should lose interest, I'd say no.
People will be a little bit reluctant to do the in-depth ophthalmoscopy because
absolutely.
everything is visible in optos.
Absolutely. So we see it. We've been seeing it, as you've rightly said. Ever since we got the ultra-wide field optos, that most of the times any posterior segment pathology, the case which is being shown to the consultant will already have a photo. And based on that, it'll be said कि इसमें break नहीं पता चल रही है, because the break might not be visible on the photo, no matter how wide field it is. But depressed exam, it is so a photo is not a substitute for a depressed exam.
Yes.
A photo is great. A photo might supersede a depressed exam in certain circumstances.
Right.
But both of them are mutually separate of each other. Are I'd say in fact complementary. And if anybody wants to do retina practice of any seriousness, I think indirect, skill is a must. I would also say, and this might be controversial to many, that a lot of postgraduates now, would not want to do indirect. And I don't think it is mandatory for them to know indirect. They should try it. They should know it. But if you don't know, it's not the end of the world. But if you want to do retina and you do not know, you either cannot or you do not do indirect, then please change I would humbly say, please change your decision and do something else.
Basically, they should know what are the drawbacks of doing the wide field photography. Basically, the inferior part of the fundus is not readily visible. You cannot detect a flat HST. Number 3, you cannot detect sometimes dialysis can be missed because anterior is doing the indentation ophthalmoscopy, you cannot get the dialysis.
Also with eyelashes, sir. And
eyelashes,
and people with deep set eyes.
Yes.
And it's very, very, you might be seeing a lot of things otherwise, but the image might not come as great because you can have a nose artifact.
Yes.
You can have lots of eyelashes which will actually impede a lot of the view.
Even within a CRA patch, a retinal atrophic hole is there or not, whether should we do laser or not, that is also important.
Absolutely.
And also the 3D structure of the image, 3D perception of the whole system of the fundus, whether any traction is visible or not, that is in a 2D picture of optos is not visible.
Yeah, for vitreous, absolutely. So for the vitreoretinal interface or for vitreous visualization, the ultra-wide field, I think the resolution is exquisitely poor for us to comment on that.
Right.
Yeah, I think you have just answered most of the things. I still would like to throw one controversial thing to you.
Sir.
Is it really very useful to have the retinal drawings when you have a good photograph with the optos?
I'd say, sir,
because you are completely visualizing everything with the colors and everything on. Of course, there is artificial colors are there.
Absolutely. So,
but when it is not so, like you take it as optos, of course, gives a lot of artificial colors.
Sir.
The add-on probably is a little better than in that. So in that case, do you really feel that the fundus drawings are going to be still critical?
Yeah, so 3-4 things, sir. I think that's a great question and multifaceted, but if I were to answer that quickly, The technology is not that widespread. I think there are a lot more people doing retina and ophthalmology than there are these fundus cameras out there. I think they're expensive. They're not easy to come by. Not everybody has access to them. That is one. I think documentation is the need of the hour, not just for yourself, for research, but also for medical legal purposes. You fix a retina and you did not have, and for most parts, for the most part, most people do not do a pre-operative retinal detachment imaging. Yes, the patient had no vision, but that's subjective. Yes, the patient gained some vision, that is also subjective, and the patient has an attached retina later on. If there's a medical legal case, you can always take a photo then. But if you do not have documentation prior to that, you could be dragged into court. You could have other things going on. Was surgery necessary? Was there a break? Was there just hemorrhage that cleared? So documentation from that viewpoint. Then also for teaching, I think it's very, very important if you have fellows, if you have people you want to teach when to do a buckle, when not to do a buckle, what is a buckleable kind of a break, what is a posterior break, do you still want to try and use sponges? I think the ultra wide field imaging kind of falls short at this point in time. I think a fundus diagram with all of those 12 clock hours, those 3 circles is a lot better because it will give you more information, also help in the teaching scenario.
Wonderful, because why I am just asked this question is because we should not take things as little lighter and then start stopping doing the indirect ophthalmoscopy or the drawings. As of today, we still need to have the documentation done properly, and I think you have very well clearly said all the points why we should be doing both. Thank you so much.
Thank you, sir.
Oh, sorry.
Yeah, I think no.
I couldn't see you.
Just a response to the last question where he's answered it properly. But the point regarding the learning the indirect and there's a subtle point over there that all the imaging modalities have, not all of them are true color. Some of them have false color. You may not on these imaging modalities be able to distinguish a hemorrhage from a pigment or an atrophic area from fluid. So when, like Mohit has mentioned, it is the drawing with color is mandatory to organize the diagnosis in your mind.
Yeah.
So when you know on a picture where to draw green, blue, yellow, brown, and black, then automatically you get to know activity, inactivity, recurrence, hemorrhage, source of hemorrhage, all those things, the picture comes into your mind and you make a proper diagnosis. So I would say as a postgraduate, young ophthalmologist, even as a retina specialist, drawing is mandatory, imaging is confirmatory. That's the best we can say it is.
Thanks, Dr. Unni. And as a glaucoma people, we are very happy with our fundus photographs than what our drawings are.
Also, if someone's a great artist, sir, if they can make an excellent diagram, they can submit it to the AIOS as a video, as a picture, as art, and get an award out of it.
Thank you.
Thank you, Dr. Mohit. So we are inviting Dr. Rupak Roy for his presentation interpretation of FFA and ICG.
Yeah, thank you, AIOC. I'll be presenting on interpretation of fundus fluorescein angiography and indocyanine angiography.
Yes, not come.
Yeah, so it's not moving actually, my slides. Yeah, so the basic principle is the fluorescein is the property of certain molecules to emit light of longer wavelength when continuously stimulated by a light of shorter wavelength. So my basic focus is to make all of us understand the interpretations. We all know this. It's the main important thing to understand here. This fluorescein is around 80% bound to serum proteins, and it is excreted by kidneys. So fluorescein angiography is to be avoided in patients with renal impairment, whereas ICG angiography is to be avoided in patients with liver or hepatic impairment. There are two barriers of fluorescein leakage. One is the outer blood retinal barrier, which is the RPE, and one is the inner blood retinal barrier, which is the endothelial cells. So first, before we go into interpretation, we should understand what are the phases of normal fluorescein angiography. When you start fluorescein angiography, the common question that is asked whenever a fluorescein angiography is started, you inject the dye, And when is the timer start? So ideally, whenever the dye is injected, the point of injection, the timer should be started. So whenever the operator is injecting the dye, same point the timer should be started. The dye should be ideally injected in a bolus dose, but if you give it in a bolus, sometimes patient have little vomiting. So just do not give it full bolus, space it over a period of 2 to 3 seconds. The moment you inject, if you put the camera on, this is what you get. You don't actually able to see anything. So what you get is, first, you are not able to see, you are just able to see the choroidal flush. So this is a transmitted something that is coming from the choroidal flush. This is where the dye enters the choroidal circulation. The important questions that everybody will ask you whenever there is a question on the plate in the FFA, that is, what is the arm to choroid time? It varies. It can be from 8 to 12 seconds or 12 to 15 seconds. Whenever it is more than 30 seconds, it is abnormal. It is usually abnormal whenever you have a pathology like an ocular ischemic syndrome or any kind of arterial obstruction. This is the time where the cilioretinal artery starts filling up. So again, very important to remember what is the arm to choroid time. As the dye progresses, this is the first time where you are able to see the arteries filling. So this is how the dye progresses. The next phase is the arterial phase, where you are nicely seeing that it is filling up the arteries, but the veins are yet to be filled. Again, the important question at this point is the arm to retina time. It is the time taken for the dye to fill up the arteries, and it is around 10 to 15 seconds. The second important time or that is to be remembered in contrast to this FFA, that is the arm to retina time. Again, this can be increased in occlusions. Then we go into the AV phase, where the veins start filling. First you have the laminar flow. This is the laminar flow, the veins start to fill. And you have the late AV phase, where the veins are completely filled, and this is known as the peak phase also, where you can nicely see the foveal avascular zone. One common question that is commonly asked, what is the AV transit time? And trust me, 99% of the times whenever the PGs are asked this question, they fail to answer this. So the AV transit time is the time taken for the dye to transit from the artery to complete filling of the vein of the same segment. This is the question that most of the people fail. They will usually tell that is the time it takes from the start of the arterial filling to complete filling of the vein. So the complete answer is the filling of the vein of the same segment, not the other segment, of the same segment. So this is a very sensitive indicator for vein occlusion, early vein occlusion. So AV transit time is filling of the same segment. This is the recirculation phase. So now whenever you look into FFA, basically you have to look whether it is a hypofluorescence, that is whether it is black, or whether it is hyperfluorescence, whether it is white. So on a mental level, you just have to see whether it is black or it is white. So we'll start with hypofluorescence. So again, you have to look whether it is black or white. So hypo means it's black. So let us see some images of hypofluorescence, then we'll see how to interpret it. So you can have a hyperfluorescence, you can have a blocked retinal hyperfluorescence. That means, see, these are the vessels, you are not able to see the vessels. So these are retinal hyperfluorescence because the retinal vessels are obscured. On the contrast, here you can see the vessels nicely. So here you have a blocked fluorescence, which is a blocked choroidal fluorescence, because the retinal vessels you are able to see nicely. Again, this is a hypofluorescence, where again you are able to see the retinal vessels very nicely. So it's a blocked choroidal fluorescence. So whenever you see a black thing, you know it's a blocked fluorescence. The moment you see a blocked fluorescence on a mental level, you have to try to unravel whether it's a retinal hyperfluorescence or a choroidal hyperfluorescence. And here you have a hyperfluorescence at the level of the disc, so it's a blocked disc fluorescence. And finally, you have a fluorescence again, just the retinal vessels are seen, but again you are not able to see below the vessels. So now, moment now you have identified what type of block fluorescence is here. Now before you go on to the next level of the diagnosis, that is the anatomical diagnosis, so the anatomical diagnosis cannot be made unless you have seen the fundus image. So fluorescein angiography diagnosis is not complete without seeing the fundus image. So now we go back to the same images now with the fundus images. So now this is a pre-retinal hemorrhage which has caused the retinal block fluorescence. Now this is a case of a choroiditis which Dr. Partho has shown, which is casting the block fluorescence. So this is a case of subretinal hemorrhage, the same patient. This is a different aspect ratio because this is the image taken on a different machine. So this is a subretinal hemorrhage, mostly caused by a disease called polypoidal choroidal vasculopathy. And here you see an entire area of blocked fluorescence, choroidal fluorescence. This is a melanocytoma of the disc which is causing a blocked fluorescence. And finally, this is, you are able to see no structural obstruction here, but all these areas are obstructed. So here you have something known as a capillary non-perfusion due to vein occlusion. So this is a filling defect. So basically a blocked fluorescence or a hypofluorescence can be of two types. One could be a filling defect where basically the dye is not reaching, or can be a blocked fluorescence. The block is because something is obstructing it. That you can only see by observing the fundus image. Now coming to the hyperfluorescence, there are these 5 types of hyperfluorescence that you can really see. They are pre-injection, window defects, leakage, pooling and staining. So lot of people have lot of confusion between leakage, pooling and staining. So I'll try to simplify them so that on a conceptual level you don't really get confused between them. So first we'll start with pre-injection hyperfluorescence. Now this is a case of a patient with trauma. This is a hyperfluorescence which you see before the injection of the dye. So this kind of pre-injection hyperfluorescence can be seen because of autofluorescent properties of dehemoglobinized blood, or sometimes in older machines due to mismatch of the filters, which was earlier known as pseudofluorescence. This is not very commonly seen nowadays. So this is known as pre-injection hyperfluorescence. So again, anything white is hyperfluorescence. Now coming to something known as window defects. So I'll start with the case first. So this is a patient. You see there are some RP alterations here. Now this is an angiography picture. This is a early AV phase. You can see there is something white. So this is a hyperfluorescence, of course. So as you are going across the faces, this hyperfluorescence is increasing. See, the size is not increasing, the intensity is increasing slowly, and again this is fading away. So now any window defect appears early in the choroidal phase. It will be maximum in the arteriovenous phase and then fades in the later phase. So this usually occurs in cases of RP atrophy. So what you are basically seeing is the transmitted fluorescence from the choroid. So it appears early in the choroidal phase, maximum in the arteriovenous phase, and fades in the late phase. This is a typical picture of a window defect. Coming to the next, so here you can see an elevated lesion in the fovea. Again, this is an early phase. You can see an early hyperfluorescence here, and that hyperfluorescence is increasing, but you can see it is very well demarcated. And then in the later stages, there is intense hyperfluorescence, but again it is very clearly demarcated in that same area. So this is a pooling where the hyperfluorescence will increase in intensity, but if you see these 3 frames, they are exactly the intensity has increased, but the area remains exactly the same. So this is a pigment epithelial detachment, and this is a typical example of pooling where the hyperfluorescence will increase, but the area will not. So window defect and pooling, you have to differentiate. In pooling, the intensity will increase, the area will never increase, because pooling occurs due to accumulation of dye into an anatomical space. In this case, the accumulation is occurring in an anatomical space, that is the pigment epithelium detachment. This is a case where you can see there is a fluid accumulation. This is an early phase. You can see a small area of hyperfluorescence here, and this is increasing. And as I go on to later phases, you can see this area is slowly increasing, and finally it has increased to a large area. And if you see, this is a case of leakage, where if you compare from this phase to this phase, this intensity of this leakage has increased both in intensity and in size. So this is an example of leakage where the hyperfluorescence will increase in intensity and both in size. So the trick is to identify the differentiate between leakage and pooling is to see the fundus fluorescein angiography from the early stage to the late stage. Do not see only one frame, always see from the first frame to the last frame, then only we'll be able to identify these characteristics clearly. There are other examples of leakage. This is the case of choroidal neovascular membrane. This is also, you can see slowly how this leakage is increased. So this is the leakage from a choroidal neovascular membrane. Some other types of leakages also we have to identify. This is the leakage from a microaneurysm, which is very common in diabetic macular edema. These are a typical type of leakages which happens in cystoid macular edema, which is known as a petaloid leakage. This is an intense leakage that we can see from in cases of PDR, which is known as disc new vessels. This is the fundus photograph. Also in PDR, you can see something known as new vessels elsewhere, or NVE. This is the fundus photograph, and this is the NVE, the fundus fluorescein angiography picture. And finally, this is a patient of a ARMD case where you can see there is a scar. And if you do fundus fluorescein angiography, this is the early phase. You can see there are small whitish areas here. But in the late stage, you can see there is a hyperfluorescence emerging here. And this is the area of hyperfluorescence. So this is the case of staining, where the hyperfluorescence which occurs at late stages. See, early stages, there is nothing much, but there are hyperfluorescence at the late stages, but it will never cross the scar margins. I have 3-4 slides left. So this is a typical example of staining. So in window defects, the hyperfluorescence starts early. In staining, the hyperfluorescence you will see in the late stages. And coming to finally to endostaining angiography, which is specially useful when you want to see choroidal diseases, and whenever there is lot of hemorrhage. If there is lot of hemorrhage, you will not be able to see anything because with FFA, because everything is obscured. So this is, I'll just show you a few examples. So this is the case that we have seen. This is a large area of hemorrhage. And see, this is the fundus fluorescein angiography. You are not able to pick up anything. This is the ICG, which is able to nicely pick up the hotspot. So this is a case of PCV. This is a case of PCV, where you can nicely see the polyps with the help of ICG. And finally, we can see RAP lesions, which we are not able to pick up with FFA. And also very effective in cases of retinal artery macroaneurysm. This is FFA, which is not able to pick up, but ICG, you are able to pick up the RAM lesions. So thank you very much. I acknowledge help of my colleagues. Thank you very much for your kind attention.
As usual, great talk, Dr. Rupak. The presenter who was supposed to talk on OCT has not arrived, so I'm directly going for like OCT angiography.
Yes, before that, I just want to thank him for his presentation.
Yes.
Thank you, Dr. Rupak. It is one of the wonderful presentations. Even I have learned quite a good number of details. Thank you. I wish that all of you stay back for some time.
Sure.
So that the PGs are here to. Yes, sir.
Yes.
Sorry.
So, can you get the information of the deeper layers of the retina and choroid, where from FFA and ICG you are getting the infex information from the fundus images, and from OCT we are getting this cross-sectional images. If you combine both of these two factors, we can get the OCT angiography, but without dye. So today I will talk about the basics as well as interpretation of the OCT angiography in few cases. I have no financial interest. So OCT angiography, it is a non-invasive technique for imaging the microvasculature and the real-time volumetric data of the retina, choroid, as well as optic nerve head. It was first described in some form in 2006, but the first published report came in 2014. The technology actually uses the light reflectance of from the surface of the moving RBC cells to accurately depict the vessels through the different segmented areas of the eye, thus eliminating the need for the intravascular dye injection. So when OCT scan of a patient actually consists of multiple individual S scans, which when compiled to a B scan provides a cross-sectional structural information, but in OCT-A technology, the same tissue area is repeatedly imaged and differences are analyzed between the scans, thus allowing one to detect the zones of high flow, that is with marked changes between the scans, when with the zones with slower or no flow. So now here we can see it is a fast and non-invasive technique. Ultra clear visualization of the microvascular flow is possible. 3D dye-free imaging of the retinal vasculature is possible, and the motion of the RBC by the sequential repeated OCT B scans is happening, where the light reflected from the RBC vessels are detected. So instead of intraocular contrast, the technology is using motion contrast by comparing the decorrelation signal between the amplitude decorrelation signal between the repeated B scans obtained at a given retinal cross-sectional to detect the blood flow, and utilizes the principle that theoretically only RBC is moving through the retinal vasculature, no other cells. So we are generally getting 3x3 or 6x6 millimeter scan. So OCT employs the two methods of motion detection. One is amplitude decorrelation, one is phase variance. Others algorithms such as OCT-based optical microangiography, that is OMAG, and split spectrum amplitude decorrelation angiography, OCT angiography ratio analysis, speckle variance, phase variance, and correlation mapping. I'm not going in details. So this is another where it is not free of tracking. You have to track the images so that to get rid of all kind of artifacts. One is real-time tracking to track the eye movement. Another is fast-track tracking to consider the blinking. The fast-track tracking and the real-time tracking both play side by side at one go, and as well as we can get the color depth images, where we are getting the red color images in the superficial layer for the superficial layer, green color for the deeper layers, and avascular zones, that is in the blue color layer. So color coding of the slab depth, it is possible basically in 4 layers. It is superficial layer, deeper layers, photoreceptor layer, as well as the choriocapillary layers. So I'll come one by one. That is, currently there are 4 main commercially available OCT angiography. I don't have any financial interest in this context, like Zeiss Angioplex, OptoView, AngioView, and Topcon and Heidelberg. This is the comparative data of all the system. Each machines having their own pros and cons, own advantage and disadvantage. But generally speaking, all machines are good. You can get information from most of the machines. Basically 4 in-face zones are currently commercially available: superficial plexus, deeper plexus, outer retina, and choriocapillaries. So superficial plexus, I will come one by one. And this is the superficial layer where from the ILM to IPL, that is possible for that is actually superficial plexus. From IPL to OPL, that is deeper plexus, and from OPL to the photoreceptor zone, that is outer retina, and RP and the deeper layers of the choriocapillaries. So basically, just a minute. Vitreous cavity is generally devoid of any vessel, so it will not give any signal. So no, as there is no vessel. When you come to the vitreoretina interface, it will normally not give any images, like as there is no when there is no structure. When there's some structure like kind of ERM or diabetic polyphatic membrane is there, or that it is some kind of traction and macular TID is there, you will get bizarre kind of picture like this. And when there is neurosensitive retina, coming to the neurosensitive retina, when the damage to the vascular, already existing vascular network is there, that means ischemic area, capillary dropout areas, you can get some kind of abnormalities, or ingrowth of pathologically changed vessel from the choroid inside the neurosensitive retina. So detailed analysis of the neurosensitive retina is possible. Like if you run the scan from superficial to deep, when you can see the pink line is going from the superficial layer to deeper layers, and at the you can just reverse it like this to get the information about the, you can see it, you can make it as just like a pause here to get the information about the new vessels. So superficial vascular plexus from the ILM to IPL that I was telling you, fine capillary networks of the with strong signals of the large vessels, you define a characteristic vascular pattern, and deeper vascular plexus from IPL to OPL, that is very dense branch capillary network up to the perifoveal areas, and avascular zones between the actually OPL to photoreceptor layer, and outer retina to choriocapillaries, that is also, it is basically for the beta detection of CNV network from OPL to RP feet, and RP feet another option is available in angioplex. Choriocapillaries, it is RP feet, but that is to 29 microns to RP feet 49 microns at the deeper layers of the into the superficial layer of the choroid, but in the superficial very thin area. So it is a very thin vascular layer, only several micrometer thickness, normally exhibit a regular homogeneous net-like vascular pattern, but choroid is giving the very dense vascular network or more deeper structure. So when you compare with the FFA, as there was no dye leakage, you will not get any diffuse hyperfluorescence, so you will get the more information about the new vessel formation or any abnormalities in the deeper layers. So, OCT angiography, you can get the layer pattern in various sections, but in fluorescent angiography, only one section, 2D picture. But in 2D picture, you can get the images in the different levels, so you can get the 3D images, and superficial layer generally giving the wave-like shape pattern distribution of the vessels, and deeper layers will give you the close-knit pattern of vessels. So when you compare with the ICG, as in ICG angiography, there is also little leakage because due to high protein binding, and but the contrast is very less. So you will get more high contrast images with OCT-A. So OCT-A is not devoid of artifacts. You can get multiple artifacts like projection artifact, shadowing or window defect, segmentation artifact, or the motion artifact. Coming to the projection artifact, almost it is present in all the sections of the, in all the images, like nearly always present in any structure that is located below the vasculature. Usually it is the blood flow of the superficial vessels which is getting projected into a deeper vessel, sometimes in the avascular zone, where normally the blood vessels should not be present. So you can, sometimes the CNV assessment is generally becomes false positive. So there are some certain software, or you can, software tool is there, like in OptoView, you can get the projection artifact removal, one option is there. You can just click it and you can get the more PR applied, and PR not applied, you can get the more clearer images when PR is applied. Like shadowing and the window effect when analyzing the layers located below the highly reflected layers, and segmentation artifact when eruption CNV can lead to segmentation artifact via the distortion of the retinal layers. So these are the things. Another artifact is motion artifact that can be arised by eye movement, which can give rise to blink lines or displacement like this in the right hand side picture, in the left hand side picture, and quilting, that is a software correction of the eye movement, which can give rise to stretch artifact, quilting, or vessel doubling. Quilting is like rectangular shaped artifact which can give rise to due to the failure of the software to correct the saccadics. So saccade movements can be avoided by using the motion correction technology, MCT, in AngioView. This option is there. So now clinical applications of OCT angiography, starting from the neovascular AMD. Biomarkers we have already identified in neovascular AMD. The active lesions can be activated can be identified by seeing that it is sheaf and shaped, or medusa pattern. You can detect here sheep and shepherd and medusa pattern here, or branching small vessels, multiple anastomosis loop, and perilesional halo. That is peripheral branching and perilesional. That is very much important in the active lesions. Quiescent lesions, the large mature single vessel filamentous linear vessels are also like the indicative of a quiescent lesion. It is getting dry, dead tree or open leaf pattern like this, absence of perilesional halo. These are all biomarkers for quiescent lesion. Coming to the cases, case CNB1, where clinically active neovascular AMD CNVM, where pre-injection and post-injection evidence. The pre-injection, there's large area of CNVM was there, and post-injection you are getting this. For the same patient, this is giving the example of multiple scans, RP, feet, choriocapillaries, but you have to give the best scan to where you can see the large area of the CNVM is getting reduced after injection. So this is the scan area. You can give multiple printed scan, or you can give the single printed scan to the patient for their better identification, also for your own research purpose. Coming to the another case where we can see that is the occult kind of CNVM with a lot of edema, CME, honeycombing appearance in the right eye and left eye also. We will not get picture detect CNVM in the way if you are scanning it in the superficial layer. You have to go more deeper at the level of choriocapillaries or ORCC level. So coming to the PCB subtypes, where the identification of branch vascular network is very much important, and sometimes you can see choriocapillaries hyperperfusion around the new vessels, so that to get the perilesional halo or underlying any areas of RP atrophy. Like in this pre-injection, you can get the BVN as well as the flow void before injection. After giving 6 injections, after 1 year, you can get see the BVN has almost disappeared, and flow void areas are decreased a lot. This is subretinal hyperreflective material. Is a very tricky situation where in the superficial images will not give you the proper picture, but deeper images you will see the CNVM. You have to detect the CNVM area. Antenna is doing that. At the level of choriocapillaries or choroid, you will not get the picture. This is another tricky situation, PFT, where you can get the information about the CNVM because in PFT there is retina thinning. Whenever there is thickening of the layers, you should suspect this CNVM. So now coming to the OCTA in diabetic eyes, where you can see not only the detection of microaneurysms as well as the macular ischemia, where the superficial vascular plexus you can get the fusiform microaneurysms, and the deeper plexus also you can get the surrounded MA, and also the detection of the capillary dropout. The superficial vessels you can identify as the orange colored vessels, and deeper layers you can get the green colored vessels. So coming to the severity of diabetic retinopathy, as the severity of diabetic retinopathy has increases from mild in pediatric to moderate in pediatric, severe to very severe, and pediatric stage, the capillary dropout area increases. So vessel density, perfusion density all decreases. So you'll get the it is a very interesting study, the quantification of the microvascular changes using OCT angiography in diabetic eyes without clinical evidence of diabetic retinopathy, because you are not seeing the patient is having any kind of single microaneurysms, but still on OCT angiography you will get the macular ischemia, the both superficial and deeper layers. So actually the cystoid spaces in DME, it appears as a flow void. This is already proved in multiple studies. Coming to the cases, like in this case, where the microaneurysms in the superficial layers, you will get multiple areas, and in another case where the patient's right eye vision is 6/9, other eye vision is 6/36. But if you see it carefully, there is enlargement of the foveal avascular zone in the left eye, as well as the capillary perfusion density. In the right eye it was 31%, in left eye it was 8.7%. Right eye vessel density was 13.9%, in the left eye density was 4.1. So that means there is definite evidence of macular ischemia in the left eye. So, okay. So coming to is another very interesting picture where left eye vision is quite good, but you can see the perifoveal large capillary dropout. So if you take the montage picture, you can get it by 6/6 or 8/8 millimeter scan, but the fovea is just spared. This is another scan where you can see this evidence of macular ischemia because of the low vessel density in the left eye. Coming to the octa in PDR, where you can get the superficial vascular abnormality as a red color picture. Down left, you can see the red colored NVE is there. Coming to the another, whether pre-retinal hemorrhage, it will give you the visceral kind of picture in the left eye, but in right eye, there is kind of CSME, and the vessel density has decreased to 34. And this is another advanced PDR that I have already shown. You will not get any picture, visceral picture. Coming to the BR view, where only OCT is not enough. If you do the OCT angiography, you will see the perifoveal capillary dropout. So you have to be very careful giving anti-VEGF injection. Sometimes anti-VEGF injection may aggravate the macular ischemia. So this is another ischemic survey. You can see whether the fovea is sparing or fovea is involved, and it is sometimes you can get the NVE picture. Now coming to the quantification of vascularity and flow information by multiple index or multiple parameters like vessel density, vessel skeletal density, perfusion density, flow index, FAZ area. So I'm giving a very, very practical example of this thing. This is case of ciliary retinal artery occlusion, where the capillary density, when patient presented, the vessel density was 3.2, and FAZ area is 0.66 millimeter square, and the perfusion density was only 6.8%. I operated that patient. That is, I did low IOP vitrectomy and AV pseudotomy and ILM peeling. And preoperatively vision was finger counting close to base, PR accurate. After 2 weeks post-op, vision improves to 6/60, and after 1 month, vision are finally 6/18. And when we did the angiography, that vessel density from after 2 weeks improves from 6/6% to 22.2%, and perfusion density improved from 3.2 to 10.2, and FAZ area decreased to 0.66 to 3.9%. After they are still showing the improvement after 4 weeks also. FAZ area also decreased in size. Sometimes OCT angiography is very much beneficial in doing OCT for the optic disc. You can get the many information about the optic disc from the central retinal artery diameter also. So coming to the full thickness macular hole, where you can get the flow void area and the hole defect, and you can get the decreased vessel density because of lack of this vascular structure in the center of the fovea. And after surgery also, slowly the vessel density improved when you do the OCT angiography. And epiretinal membrane also, before pre-op and post-op and after surgery also, you can do the OCT angiography to see the to justify your technique. And so today, what is the need for OCTA? It is to avoid the dye-related complication of FFA. Number 2, to assess all vascular layers at different sections of retina and choroid, and to get first high contrast, high resolution anatomy of the microvasculature. Thank you.
Thank you so much, Dr. Subhantu Boral. Any questions to him, or any comments from retina practitioners? I'm not a retina guy. Anyone wants to give any comments or add on points? Thank you, sir. Okay. The next talk is by Dr. Unnikrishnan. Dr. Unnikrishnan Nair, and he'll be talking to us on the concept of multimodal imaging and clinical applications. Though I have listened to many times on this particular talk, I still would like to listen to that.
Thanks to the AIOS for the invitation for this talk. So, a couple of things you have to know regarding any imaging modality is that the whole is greater than the sum of the parts. You have to look at everything together. The next thing is order a test only if you know what to do with the result. The typical example being Brexit. People ask for the Brexit, and once they have the reaction, they don't know what to do about the Brexit. So that's one thing. Imaging can tell you only the processes that happen. They don't tell you the diagnoses per se. And there are patterns all over the place to interpret. So multimodal imaging is a group which you have all these imaging modalities together. So and what is the importance? The concept of multimodal imaging is that they tell you some stories. So let's go through some of these stories. So you have first, we'll deal with geographic atrophy. You have so many imaging modalities, but this is the essentiality. What do they do for you? First, they give you a definition. So everything is now called, it's not called geographic atrophy, it's called macular atrophy, and this is it. It's divided into something called C-RORA, I-RORA, which I'll tell you. And that itself, you can have with and without neovascularization. So this is the new classification. And what do you mean by C-RORA? So this is what it tells you. It helps you to define what atrophy is. C-RORA is when you have a contiguous area of more than 250 microns over there where there is no outer retina, no RP, and the whole transmission. This is the transmission defects. You see that the light is transmitted, and that's called the transmission of more than 250 microns. And this is an example when you see geographic atrophy, but when you see the extensive transmission more than 250, this is called C-RORA, complete RPE and outer retinal atrophy, C-RORA. And then you have, obviously, if you have C-RORA, you'll have I-RORA, or incomplete, when it is less than 250 microns. It's a small area of atrophy. So first here, now geographic atrophy is given a name, two names, C-RORA, I-RORA. And next comes to the next story. The next story being hyperreflective dots. Why is this important? You see small dots. So these dots are called hyperreflective dots. They're the first sign of RP atrophy. So that's the story. You can predict RP atrophy, predict geographic atrophy. So you see these dots, and there you see the PED flattening. And these are another example. This is yet another example of hyperreflective foci. You see the RP cells detaching from the RP, the first sign of atrophy. And this is a 10-year-old follow-up. You see the dots, you see the changes happening, and you see atrophy happening over a period of 10 years. And this is a good example of geographic atrophy happening.
Dr. Undi, can you just disturb? Can you just use either the what do you call no, just to show them the PGs.
Yeah. So
Either the mark. Yeah.
Yeah. So I'm using it. It's not very bright. That's a problem. Okay.
Can you use that tracker?
Yeah. Okay.
Yeah. So that they can really understand what.
Yeah. So the previous we were showing the atrophy. This is another thing. It's called hyperreflective vertical columns. So what I want you to look here is that, do you see these vertical columns going up and down? So when you have a small area of RP, there is a hypertransmission going beneath it, which tells you that the RP is getting atrophic at that particular region, and you see these hyperreflective columns. And this is yet another column. Here there is no RP, so the OCT light gets transmitted to a deeper layers. It's called a hyperreflective tail also, it's called. And you see this, and when this happens, it leads to a condition called nascent geographic atrophy. That's a geographic atrophy that's about to come. It's called nascent because you see here, you see the layers dipping down. That is because there's lack of vertical support and the layers go down. So this is a particular condition. It's called nascent geographic atrophy. It precedes geographic atrophy. The classic way of measuring geographic atrophy is using yet another tool called fundus autofluorescence, where you see, this is a typical description over a year period, you see a nose getting attached, which is islands of geographic FAF, that is fundus autofluorescence hypo. Hypo means there is no RP and it gets enlarged, and this is how you measure dry AMD. There is yet another modality where you look at the in fundus autofluorescence, you look at the area around the hypo place. If you see hyper autofluorescence, and therefore it is divided into multiple patterns, and of which a pattern called the diffuse reticular pattern has the greatest. So now you have a way of identifying GA before it happens, measuring GA, and also predicting how GA progresses. So the take-home message from this is that you have a disease where you can identify, now you know how to define it, how it comes, how it progresses, and how to measure using some additional characteristics of OCT. Now let's look at wet AMD. So the angiography part has been well done. I just want to make one point here. There is a very important, you just need two angiographic patterns, an early pattern and a late pattern. The early pattern, if you see here, it gives you the definition of the angiography in a classic, and the late pattern shows the fuzziness. So early definition of a classic CNVM in an early angiographic picture, and fuzziness in the late, that is a typical diagnosis of a classic CNVM. And the classic OCT diagnosis is a fusiform lesion like you see here. So you see in this particular picture, you see all the angiographic lesions, but the OCTA brings out the next thing. It's called a vascular net. A classic shows a typical lacy pattern vascular net. So the OCT is very useful for classic membranes, not so much for occult membranes. So there are various patterns. You have the lazy pattern, the Medusa pattern, where the central vessel is the center and like a halo it goes all around. Then you have a sea fan pattern when it goes only on one side, and then you have a fishnet pattern. And why are all of these important? Because the response to treatment is different. So now you have a disease where you can identify the different patterns and know when I give anti-VEGF, it may not respond well, it may respond well. And why does it happen? You have recurrence. And this is, I want you to keep this image ingrained in your minds. This is a typical image of a recurrent CNVM. What happens? You have an anastomotic channel going all around the membrane. And then you have small vessels attaching in between it. This is the typical picture of a recurrent CNVM. When it comes, you have the anastomotic membrane followed by the internal lesions. And here you see another picture, anastomotic membrane around it, small vessels in between it. Here you see two parts. The part I'm showing you here is a regressed part, filamentous vessels. And the part I'm showing you now is the active edge, where you have the small vessels recurrence. So OCTA is an important modality to prove to you recurrence of a CNVM. So this is along the same lines. Okay. But when you know that a CNVM is going away, this is the appearance. It's called a prune tree or a dead tree. All it means is that you have long filaments without any intervening small vessels that I showed you. That shows that the CNVM is inactive. And this is another, it's called skeletonization. You can see the pattern. All the vessels look like the typical radiological skeletonized appearance, where there's no consistent flow inside them. So this is an OCTA picture of a skeletonized or a regressing membrane. So we'll just skip this, and this is an important thing to know. This is one we said, how do you predict a CNVM? So this is the thing, it's called a non-exudative CNVM. You have a picture here which looks pretty much normal. There is no activity except for this. This is called a double layer sign. What is it? It's a separation of the RP from the Brooks membrane. You see a small gap over there, but there is no activity. And when you do an OCT angiography, you find there's a vascular network over there. So you have a vascular network, or what you would call a CNVM, but there is no fluid or hemorrhage. This is called a non-exudative CNVM. This is a picture, another picture of a non-exudative CNVM. And why is it important? Statistically, up to 22% of non-exudative CNVMs become full-blown CNVMs in 1 year to 15 months. So that is why you have to identify. So angiography still, the story is that angiography is used for some diagnosis, not all. OCTO gives you different types of vascular nets, so you can predict response patterns. OCTA allows you to find recurrences, and a diagnosis of non-exudative CNVM, if you can find, you can tell the patient to be careful for the next 1 year to make sure that the patient doesn't get a full-blown CNVM. Pachychoroid. So pachychoroid is something that you know, CSR, there are many manifestations, and on the right-hand side you see dilated blood vessels, choroidal blood vessels. I'd like you to see this picture. This is a picture of the vortex vein engorgement. So this is the pathogenesis. The vortex veins are engorged, there's an outflow problem, and that is transmitted to the choroidal circulation. So this is upstream. And then as you go downstream, you have thickened choroidal vessels. Pachychoroid. This is how pachychoroid happens. And when pachychoroid happens, you can have a full thickness, and you can have just the halar vessels getting thick. So this is upstream and downstream pathology of pachychoroid. And this is what happens. When the problem in pachychoroid is not because of the thick choroidal vessels, it's because they cause inner choroidal attenuation. They cause the inner choroid to thin out, and that's why you have your CSRs, and all those conditions are because of the ultimate downstream effect, that is the inner choroid being thinner. Picture, you all know CSR, and this is what I like to show. You have a color photo or multicolor, and this is all it shows you. It shows you a thickened vessel here, it shows you SRF here, it shows you a possible PED here. So all the information you require is available in this multimodal diagnostic tool. And again, autofluorescence is a method to identify different pictures. I just like to show you one thing. This is a picture of a tract forming, an RP tract where fluid was there, and the fluid caused damage, and it hyperfluorescizes over time. And eventually it forms this disease in which you call it a decompensated CSR or sick RP syndrome or diffuse RP epitheliopathy. This is a new diagnosis or recent diagnosis called PPE or pigment epitheliopathy. you have a pachychoroid vessel over here, a thick vessel over here, and something on top of it, that's a problem. And when you look at it carefully, you have all these small changes on the surface. And I'd like to show you just quickly what these changes are. You can have a small split in the retina or a small elevation that looks like a drusen. So this is why is this important? Again, the story here is that in some cases it has been described that through this small break you can have a new vessel forming. So this potentially could be a precursor lesion to pachychoroid new vessel disease, and that is how important diagnosing these conditions using multimodality is. Another condition called pachychoroid neovasculopathy, here it looks virtually normal, nothing is seen, but at this area you see a small lesion, and on OCT angiography, which is a diagnostic tool for pachychoroid neovasculitis, you have a thick choroid, but it doesn't go to PCV, it just produces a small membrane, a type 1 membrane. This is called pachychoroid neovasculopathy, and this is how you see the membrane over here. So again, PCV, you have multiple modalities. You see basically in PCV, you see a group of polyps, you see a thick branching vascular network, or BVN. That's what you see over here, a BVN with polyps at the tip. And I'm just skipping these two, those are videos. And this is the typical appearance. You see a peaked or thumb PED, notched PEDs, a double layer sign, SRF, and intraretinal fluid. So these are the critical diagnostic features of a PCV in one slide. And obviously the pachychoroid. So this is a representation of how the polyps look on ICG and fluorescent. Now polyps are not called polyps. This is one I want to highlight. They're called PLs, or polypoidal lesions. BVNs are not called BVNs, they're called BNNs because they've been discovered to be neovascular. So this is, if you want to talk like a retinal specialist, this is how you talk nowadays. But what I want to show this slide is that we've discovered that BVNs are not uniform. There are many types of BVNs. Trunks, glomeruli, and sticks. They're different appearances. And why is this important? This explains to you that PCV is not a uniform disease. There are multiple variations, and that is why they do not respond to anti-VEGF uniformly. So I'm just going to skip this wrap because it's a bit too complicated even for me sometimes. And we'll go to one of my favorites, MACTEL. MACTEL is a very strange disease. Sometimes difficult to diagnose, sometimes stares at your face, sometimes you don't know what to do with it. So here you have two pictures on both sides. The same picture, one is using multimodal imaging, color, true color confocal, and you see everything brightens up. Just a few more slides here. Everything brightens up. The same picture in regular fundus photography, you don't see anything. So multicolor enhances the pigment, enhances the atrophic areas, and is pretty much diagnostic in MACTEL also. Here you see something different. You see a small hemorrhage over there. And this is what happens in OCTA in different levels. You see different things happening, but eventually at the avascular zone in the end, you see a blood vascular network happening. Okay, this is the CNBM on OCTA in the avascular zone, which is normally supposed to be empty or devoid of any vasculature. So these are the other features of MACTEL. You have inner and outer lamellar defects. You know all these things. There's something, a thick plaque over there. This is called a pigment plaque. Subsidence, when the tissue collapses and falls and goes towards the outer retina, you see the tissue going down over like this is called subsidence. And there's a new change called ORA or ORAH, where you have all these lesions down in the lower part over here. And the typical end stage of MACTEL would be an SRNVM. Note it's not a CNVM, it's a subretinal neovascular membrane. And what do you think of the pictures on which side? Which is a SRNVM, the right or the left picture? Is it this one or this one? Are both of them SRNVs? The right or left? This or this? Both. Okay, you're right. The one on the left because I told you about 5-10 seconds earlier, that's the SRNVM. The one on the left is an artificial artifact caused by atrophy. The vessels go down and it looks like a CNVM, but it isn't. I'm just skipping. Diabetic retinopathy, you know absolutely everything about it. This is a typical wide field. This is not an ultra wide, it's a wide field picture. It captures everything. This is an ultra wide field picture. It captures everything, but it's hard to interpret sometimes. A typical picture of DME with the typical features: submacular detachment, spongiform edema, cystoid macular edema. Your three edemas that you have to deal with. Disorganization of the inner retinal layers, it means this. On this side, you see all the retinal layers clearly. On this side, you cannot make out the inner retinal layers. This is called disorganized retinal layers. This is parallelism, when the layers become not parallel to each other. Again, you have a hyperreflective dots, disruptions, and I'm just skipping, these are not so critical or crucial. So this is what you need to know. This is a crunch phenomena. When you do too much laser or too much anti-VEGF, this is what happens, and this is beautifully picked up by wide field photography. A normal FAZ, and how many of you think that this is macular edema, ischemia? Nobody thinks it's macular ischemia. Do you see the FAZ enlarged? Okay, is it macular ischemia? Yes, no? Okay, it's not macular ischemia essentially. This is an interesting way of using multimodal edging. Do you see the cystoid macular edema there? The macular edema has pushed all the vessels to the side. So when you do an OCT, it looks like macular. So this is kind of, when you treat the CME, the vessel, the FAZ becomes smaller again. So this is a crucial thing to know, that you have to correlate two methods of evaluation, not just one. So last part, this is a game changer in diabetic retinopathy, ultra wide field imaging. Why? Because now you have the ability to recruit more, find more PDR in the periphery, find more ischemia, treat lesions better, and please know that peripheral ischemia is now related to unresponding diabetic macular edema, and that is why ultra wide field imaging should be a part of the diabetic workup nowadays. So thank you very much. These are some stories you can learn about all these things. Thank you.
Thank you so much. I'm sure that we just have some questions to ask. I know that you have a lot of photos to show. Just want to compliment him on one thing, that what if PGs or somebody wants to attend the retina meeting, which he conducts year on year, one of the very good meetings. Probably you can just mention which month. I just forgot the month.
July 26, 27, 28. On the 28th of July, we have a specific basic retina imaging course only for postgraduates that day. So 26, 27, 28 is a retina imaging congress in Trivandrum, and 28th is the BRIC, the basic retina imaging course. So you're all welcome to come. Yeah. Registration is free.
Thank you.
Thank you.
Thank you, Dr. Oni. And we have our last presenter, Dr. Purna Chandra. Sorry for holding on to you, Dr. Purna Chandra, for your last talk. He's going to talk to us on the clinical interpretation of the ERG.
So good evening, everyone. So electrophysiology, okay. So something which I couldn't understand even as a postgraduate, and I used to run away from the electrophysiology because it's very volatile and little difficult to understand. So that's what I was thinking, but it's not so. And before you start studying about something, you need to ask, why do you need that, okay, as a postgraduate? So one thing is, as an ophthalmologist, irrespective of your specialty you practice, you need to know some basics about electrophysiology. And you may get a theory question on this one. And in practicals, if you're a DNB or this thing, in some station, they will keep these printouts as a spotter. They will give you just read this. And also it's very important if you're planning to give an FRCS exam, or if you're planning to appear for a retina interview. So you are expected to know some basics of electrophysiology.
So you're just making sure that they all listen to you now.
Exactly. So fine. So first, let's start with the definition. What is an ERG? It's the mass response of the retina to a luminance stimulus. You stimulate the retina with the light, there will be biochemical and ionic changes in the photoreceptor and the RPE, which generates electrical potential, which is recorded as electroretinogram. Okay, simple. So we know that ERG has PQRS waves, right? Similarly, in ERG also we have some waves. A wave is from the outer retina, that is from the photoreceptors. B wave is from the inner and the middle retina, predominantly from the bipolar cells with some contribution from the Muller cells. So we have some, the fluctuations along the ascending limb of this B wave, which are called oscillatory potential, and these are from amacrine cells. Most of the time your viva will end here. They will ask which wave is from here and all that, and if you answer well, so they may go on to ask next question, next set of questions. And when it comes to ERG, there are different types of ERG which you need to know. One is the full-field ERG, which is the response from the entire retina. The pattern ERG is predominantly from the posterior pole. And multifocal ERG, we check each and every point on the posterior pole, that's on the macula. Okay, that's the difference. ERG means it's not the single thing. There are different types: full field, pattern, and multifocal. I'll explain the differences. So this is how a typical full field ERG printout looks like. I'll go to the individual waveforms to make you all understand better. So the full field ERG recording starts with a typical dark adaptation where the patient is made to sit in a dark room for 20 minutes. That is minimum of 20 minutes. It will be pitch dark room. In that dark room, we'll patch the eyes also. During this 20 minutes of dark adaptation, in case if there is a little light exposure also, you need to repeat this 20 minutes again. So what are we trying to do here by patching the eye? So we are trying to silence the cones, and we are trying to elicit only the rod predominant response. So that's what happens in the dark adapted state. If you stimulate the retina with a very small intensity of light like 0.01 candela per centimeter square, you get a big positive fluctuation which represents rod activity. Okay, so once you increase the intensity of stimulus, the A wave starts appearing, the cones also starts contributing. This is what we call as combined response. So there is contribution from cones also and rods also. So then we light up the patient for 10 minutes, minimum of 10 minutes. We'll make him sit in the ambient light. So in that light adapted state, if you stimulate the retina, what we get is a predominant cone-driven response. I'm using the word predominant. I'll tell you why. Because in the same light adapted state, if you stimulate the retina with a 30 Hz flickering light, so what you get is a response which is only cone-driven. So because rods cannot respond at such a high frequency, so what you are getting is an only cone-driven response. So it is simple. Whenever you get an ERG printout, you need to just look whether the rod component is affected or a cone component affected or both are affected. So clear? We started with an isolated rod-driven response and ended with an isolated cone-driven response with a spectrum in between. So, and there are two terms which you need to know. This is basics what we learned in our 11th and 12th. So that's the implicit time and amplitude. So the definition what we learned in physics, same definition holds good here also. Implicit is nothing but implicit time is from the onset of stimulus to peak or trough of wave of interest. For example, implicit of A wave from onset of stimulus to till the trough of A wave. Similarly for the B wave. So amplitude is measured from trough of previous wave to peak of wave of interest. Okay. So when you look at the ERG abnormality, these are the only two things you need to look at. Whether the implicit time is prolonged or amplitude is reduced. These are the only things which can be abnormal. Okay. So then coming to the ERG reporting, as I told, first look at whether the rods are affected more or cones are affected or whether both are affected. If both are affected, you need to mention which component is more affected. The rods are more affected, cones are more affected because there are different types of dystrophies like rod, cone, rod, it all depends on that. Because clinically it's impossible to differentiate. And there are sometimes you may get something called negative waveforms. I'll explain the same with a case example. So that's about full-field ERG. I'll show the case examples later. So coming to the pattern ERG. So in the full-field ERG, the stimulus what we used is a luminance stimulus. This is just we stimulate the retina with a light. Here in the pattern ERG, as the name suggests, we use something called checkerboard, and there is no contribution from the peripheral retina. It's predominantly from the posterior pole. So here you have a very big positive deflection called P50, which represents macular functions, followed by a negative deflection called N95, which is useful for assessment of retinal ganglion cells. Clear? So for example, if you have a glaucomatous optic atrophy patient, if you do a pattern ERG, you will get a normal P50 and an abnormal N95. Okay? And if you have a patient with geographic atrophy, advanced AMD, so the P50 will be abnormal, N95 will also be abnormal because unless the photoreceptor fire, the ganglion cells cannot conduct. So it complements the VEP to distinguish between an optic neuropathy and maculopathy. So for example, if the P50 is affected, you are very sure that the macula is, there's something wrong in the macula. So similar way, it complements the full field ARG, whether any particular disease is macula sparing or macula involved. Okay, for example, if you have a normal full field ERG and only pattern ERG is abnormal, that means the disease is localized to the macula, except macula, rest of the retina is normal. Okay, if both are abnormal, then the disease is quite extensive. So multifocal ERG, as the name suggests, it allows even a small foci of retinal dysfunction. We use either 61 or 103 hexagonal elements to stimulate each and every point on the macula. So at any point of time, only 50% of these are illuminated, and you get a graph corresponding to each and every point on the macula. So that's how it's able to detect even a small foci of retinal dysfunction. So most of the times we use multifocal ERGs in drug toxicities. So let me show some case example. This was a 10-year-old female. If you can see the fundus photo, I don't know whether you can appreciate in this color photo, there is a macular atrophy. So this patient was born out of a consanguineous marriage. And if you look at the autofluorescence, the atrophy is better seen, and there is a corresponding outer retinal atrophy and the OCT. So this is a case of macular atrophy with multiple flecks. It's a case of Stargardt disease. Okay, fine. So let's see, we'll do the ERG on this patient. If you look at the ERG, the blue wave belongs to the normal, the black line belongs to the patient. If you look at the dark adapted responses, this wave was supposed to start here, but it's starting here. So implicit time is delayed. So the amplitude also, instead of going till here, the wave amplitude is grossly reduced. So implicit time is also delayed, the amplitude is also reduced. The same thing can be seen in the combined responses also. So this is the dark adapted. Look at the light adapted responses, which are predominantly cone driven one. The similar picture. The wave which is supposed to start here is starting here. Implicit time is grossly delayed, and amplitude is also decreased. So what does this indicate? There is a cone rod dysfunction. That's all you need to say. So by looking at the ERG, you can't tell like the diagnosis is cone rod dystrophy or anything. If you do a PRP for diabetic retinopathy, if you do an ERG, then also you'll get a similar thing. Okay. So whenever you give an ERG for an interpretation, you need to just tell what is affected, what is the thing. So describe the implicit time, amplitude, cone component, rod component. Okay. So you might ask, sir, why are we doing ERG in a Stargardt's patient? So what is the use? Because based on the response of the ERG, Stargardt's can be of 3 types. If the type fulfilled ERG is normal, that means the disease is just localized to the macula, in which the chances of progression is almost nil. If only cones are affected, there is a 20% chance of progression. If both cones and rods component are affected, as in our case, there is 80% chance of progression, in which it will also help to prognosticate. Okay, so that's what patient asks now. When you diagnose something for which there is no treatment, the next question will be, what will happen to my vision? Okay. So fine, this patient, when he did a genetic testing, obviously had ABCA4 mutation, which is known to cause Stargardt disease. So this case is a 22-year-old male who presented with a diminution of vision in both eyes since childhood. Vision was around 636. He had history of photophobia, and both eye fundus was normal. In fact, wherever he went for consultation, they all thought this patient is malingering, okay, because everything looked normal. So he came for my opinion. So when I did an autofluorescence, it looked more or less normal. But if you look at the OCT, so definitely there is a defect in the foveolar region, which mimics a kind of photic retinopathy. That's what we thought. So, but we did an ERG, just look at the ERG responses. Again, go by order, dark adapted responses and combined responses, both are absolutely normal, okay? So its rod system is functioning well. But look at the light adapted responses, it is flat, it is undetectable, okay? So this is a case of achromatopsia, which is a form of stationary cone dystrophy. Cone dystrophies can be either progressive or stationary, only ERG will differentiate. Okay. So most of the time in achromatopsia, fundus could be normal, vision could be variable. When you check the color region, it will be grossly abnormal. Most of the time they fail to identify even the single plate on the EyeShala chart. So clear? So if not for ERG, this patient would have been falsely labeled as photic retinopathy or some malingering and things like that. Fine. So this third case is 80-year-old male who presented with blurred vision with a vision of 636. If you look at the fundus photo, the foveal reflex is not well defined, and there is a non-specific RPE mottling in the perifoveolar region. And look at the OCT, very classic. What is this? It is given as a spotter. Yes, you're right. So it's a X-linked juvenile retinoschisis. Okay. So when you do an ERG, sometimes they can have these vitreous veils which can lead to hemorrhage and all that. So that's a different topic altogether. When you do an ERG in X-linked retinoschisis, because the OCT picture may not be classic all the time. So sometimes you may have varied picture. Now look at this, I put only the dark adapted responses. If you look at here, the implicit time is prolonged, amplitude is also grossly reduced, okay? And if you look at this combined response, there is something interesting. The A wave is forming, the B wave is not even reaching the baseline. You can see the same here, A wave is forming, B wave is not even reaching the baseline. So this is the classic electronegative ERG, okay? So what you get in any diseases when there is an inner retinal dysfunction. So what's happening in juvenile retinoschisis? Outer retina is fine, photoreceptors intact, but inner retina is split. So B wave is from inner retina, bipolar cells. So similarly, so if you are in FRCS, you will get typical question like electronegative ERG is seen in all except something like that. So think logically, whatever that affects inner retinal function, you can get an electronegative ERG. For example, CRAO, what happens? So outer retinal circulation is still intact, their function is normal, inner retina is gone. If you do an ERG, you will get an electronegative. Similarly, ischemic CRVO, so you will get an electronegative ERV. That's the traditional, you keep reading, no, reverse B by A ratio, it's all about this. And also there is some form of congenital stationary night blindness disorders where there is a, some problem in the bipolar cell conduction, you can get electronegative ERG. So never try to mug up things, try to understand it by logic so that you can remember better. So this case is a patient of 26-year-old male who presented with night vision problem. The distance vision was decent enough, 6/9 and 6. The fundus photo very classic, okay? It's a case of retinitis pigmentosa. So when you do an OCT in retinitis pigmentosa, this is what you get. If you look at the outer retina, the ellipsoid zone is present only in the foveal region, so it's not present in the parafoveal region. That's the reason they have tunnel vision. So let's see what happens when you do an ERG in this patient, full field ERG. Look at the dark adapted responses, undetectable. Combined response, undetectable. Late adapted also undetectable. The reason being, the photoreceptor which are present just in the foveolar region are not enough to elicit a full field response. If you see a classic case of retinitis pigmentosa, there is no point in doing full field ERG. You will get response most of the time like this. It is helpful in case of sometimes sign pigmento cases where it's not very classical. If you want to do an ERG for some monitoring purpose and all that, what you do is a pattern ERG or a multifocal ERG. Okay, because the reason is I get lot of requests for ERG, RP ERG and all that. So there's no point. So the last case, this was a 54-year-old female housewife, came for cataract surgery, interested in multifocal IOL, and it's a fashion, when the patient asks, they ask for, so can you go for multifocal? But this patient had history of taking hydroxychloroquine for 20 years for rheumatoid arthritis. So as the screening, fundus appeared absolutely normal, OCT was also normal, autofluorescence was also normal. But look at the multifocal ERG, the central points are grossly depressed. Okay, there is a subclinical foveal dysfunction. Okay, so that's the beauty of ERG. It can pick up things before the structural changes can occur. So will she be happy if you put multifocal IOL? Don't even think of that. You will be behind your life. Okay, fine. So sorry, this is the last case. This is a 26-year-old male presented with low vision since childhood, 6/24, 6/24, but surprisingly near vision was good, N6. So this is the fundus photo. Right eye had almost an excavated lesion and left eye had foveal thinning in the outer retinal loss. So we did an ERG. This is the ERG. So full field ERGs, just go by the order. Implicit time, amplitude, everything looks fairly okay, both the actors. This is a normal ERG, okay? So what does this indicate? This indicates this disease is just localized to the macula, rest of the retina is normal. Okay, so this is a case of congenital toxoplasma scars. So most of this time these lesions are intrauterine, so by birth itself they will have extrafoveal, that's why the PRL, that's a peripheral retinal locus. That's why vision is relatively better. But if you give the OCT and if I ask you to predict the vision, you will never tell it's N6/6/24. Okay, so basically ERG is telling it's a localized disease, entire retina is normal, the prognosis usually it's good. Okay, they're not going to go blind. So to conclude, I would like to say electrophysiology is an important tool to aid the diagnosis. It should always be followed by clinical correlation. So never take any particular investigation in isolation. And in case if you guys are interested in learning more about electrophysiology in detail, we have a session tomorrow at 1:30. So all of you are most welcome to attend that, and thank you so much.
Thank you, Puneet. So I'm sure that all of you here understand that ERG is not that difficult, but it is little difficult, but it is pretty useful. So we used to make fun of the retinal people. You are seeing an RP, then why do you really want to see the ERG? So basically, he has mentioned that it is important to tell the patient's prognosis, which stage or the type of the pattern they have, so that we can mentally prepare them, or the family members, we can tell them the likely chance of progression is very less, say only chance of 20%, chance of 50%. So we can really prepare the family, otherwise all these things can cause a lot of depression in the family. So it is pretty useful, so that is what we really need to understand. Whatever said and done, we still pull the retina back.
Yeah, but of course, I just showed the examples of inherited retinal dystrophies. There are some many non-dystrophies indication for ERG, like vitamin A deficiency, some of the toxic neuropathies where VEP and all that, and autoimmune retinopathies, carcinoma-associated retinopathy, where without ERG, literally you can't diagnose. I mean, patients will be moving from one consultant to another consultant, taking second, third, fourth, fifth opinion. So ERG is like final thing. There's nothing beyond ERG in ophthalmology. That's the highest investigation what you can do. So this is the only thing where you can tell the functional integrity. Okay. Yeah.
Just
Yeah.
for, we all know that the HCQ toxicity, the traditional teaching is you do the color vision, you do the visual fields, and to extend nowadays, people started doing the OCT. And many of the times I also do see that you don't really see a big change. Unless you do the ERG, we do have the ERG, but you have a different ERG, I have a different ERG. But then, again, the findings are almost the same. But then how often in your practice, in Narayana Netralia, that you advise the patients you don't have to go to all that, you directly do the ERG, and then we can find out whether you have the toxicity or not.
Yeah.
Because clinically, patient will never have, most of the times I'm saying, most of the times they don't have much of a problem to come and complain, rather than the rheumatologist referring us to rule out any HCQ toxicity. And also, we are facing a lot of complications with the ATT, which is completely changed now. The treatment of ATT is changed now because the ethametral has been continued throughout the course. It is not only for the first 2 or 3 months, it has been continued for 8 months, 9 months now. So how often you clinically really use the ERG?
Yeah. So to answer your first question for HCQ,
I really want you to understand this is becoming a mandatory thing, that whether it is for your exam or not, it is for your regular practice, it is extremely important, because we started seeing more and more numbers now.
So to answer your first question regarding HCQ, there are clear-cut guidelines from AIO, American Academy. So we need to do the screening test 2 years after taking the thing. Before that, we usually don't stop. There are a set of tests which you need to do, as I rightly mentioned, the color vision, OCT, fundus autofluorescence, multifocal ERG, and fields 10-2. So in order to request to stop the HCQ, 2 of these tests should be abnormal. If any one is abnormal, if rest of the things are normal, you can definitely ask them to continue. If 2 are abnormal, you have to give a letter to the rheumatologist stating that this is what's happening. Maybe it's better to stop or consider alternative or reduce the dosage, like maybe 300 BD from 200 mg BD or 300 mg OD or something like that. That is the thing. Of course, when you see obvious patches like of atrophy, because what is the textbook description of bullseye macula, all those things are not seen. In fact, Indian patients, it's all very rare.
I haven't seen one.
Yeah,
actually.
exactly. So don't expect that HCQ means you will wait for bullseye maculopathy. So that is not there, because even legally also it becomes very important, you pick up these changes. So that is the standard guidelines. In my practice, I do it baseline. So though the AO tells after 2 years, because unless you compare patient's own readings to its own this thing, it's not make.
Absolutely.
So before starting HCQ, I strongly, recommend that all rheumatologists do a baseline of all these tests.
Correct.
Do it after 2 years. If there is no change, do it again after 2 years. If there is very subtle change which you are not sure, repeat after 6 months. Then take a call depending on how many sets are abnormal.
Is it really you go with the 2 years pattern, or is it that you go with the dosage pattern?
I didn't get this. Come again.
Is it based on the dosage pattern you go with the 2 years, or is it just everybody
No,
you have
no,
a 2 years?
2 years. 2 years is standard. As of now, they were not subclassified based on the dosage pattern. These are the general guidelines. Because the reason being, the sensitivity or susceptibility to different doses could be different because of the melanin factor, genetic factor, many factors. Someone taking 600 mg OD could be, resistant, they could be normal. We have seen patients who are taking 100 mg OD developing early changes and all that. So, and also
The simple reason is again,
yeah.
the rheumatologist, most of the time they give only continue as the 200 milligrams.
Yeah.
But the non-rheumatologist, everybody today practices almost every kind of thing. So that is where the problem is. Somebody is on 400 irregular.
Yes, that
So
is.
those are the patients where we feel little different to, come to only 6 months, 2 years or 1 year. We really don't know.
And because this is something this is like a magic. Most of the patients are very comfortable when it comes to
Exactly.
their rheumatoid symptoms with HCQ. The moment we stop, the other
Yeah.
things they don't tolerate.
Yeah.
You have to have a strong, it becomes tricky when they develop, in 60-year-old comes with these things, they have the AMD changes also, you really don't know. In that case, I'll stop. Anyway, the macula is sick and there's no point in continuing a drug which is expected to cause macular toxicity. To answer your second question on the ethambutol thing, so the ideal thing would be to do again the baseline VEP before they start. And I strongly recommend do it at 1 month and 6 months. If you see any changes in the pattern, not the flash ERG, the pattern VEP, then not the ERG, VEP, the flash
That is
pattern
exactly I wanted them to understand.
Yeah, I couldn't.
When will you do, though both are drugs,
Yes.
oral drugs, but one you have to do a VEP and other one you have to do a multifocal ERG. That's the reason, exact reason why.
So, because you need to know, whenever you order electrophysiology, you need to know what are you trying to look at and what is expected. For example, as sir asked ethambutol, here you are looking at not the macular toxicity, the optic now. So that is the one. So you need to do a baseline color vision and the VEP and all that. And when the patient comes with blurred vision, we all know the game is lost. Most of the time, you can never recover that vision. In case if you see
Ethambutol toxicity, typically the patient will come with poor vision.
poor vision, yeah. So a very, again, tricky situation. Ideal would, I know that it's very difficult because everyone will not have access to VEP, and the VEP, what neurologists do, they only know what they are doing. So
I wouldn't comment on that because I try to understand, but I never understood their
because
VEP.
they also don't understand. So simple as that.
Hope
So
nobody is here.
maybe husbands,
Do you
spouses
have
could be
in
there.
this, 1 second, do you have the ERG that you do it in your regular practice in Disha?
Yes, especially whatever the diseases is RP, progression of Stargardt's disease and road cone dystrophy. Like in this, all these things, we have our ERG as well as the VEP, all the combined machines.
Because why I asked this particular question is more than the rod cone dystrophy, what we see commonly is the
Yes.
ethambutol and the what do you call the HCQ.
HCQ toxicity,
yes.
We clinically we are not really doing much.
So that's the reason I showed that case example of HCQ toxicity. multifocal
Basically,
vision.
in the books of rheumatology, they have mentioned that in OCT you will get the earliest sign. But for us, when we are not detecting in the either in field or color vision or in OCT, you have to go for the ERG. That is
For me, it is almost 95 to 97% of the time I don't find any change in the OCT or the visual fields in the HCQ.
OCT is very
Very rare. But I have seen quite a good number of them having a change in the ERG pattern. Multifocal ERGs are one of the most useful things. Whether by stopping the HCQ, whether it is improving or not, I have no idea. But then at least I give the caution to the rheumatologist that can you just change over to something else. Yeah, that's the one thing, which I think the PGs and others also can really use it. Any other retina people here who are using the ERG? So there are two different patterns of ERG. The one which he uses probably takes a little longer time. You have to do the dark adaptation. And then you are doing the one which I have. I'm not getting the name of the machine.
Diopsis, sir. I know.
Diopsis, yeah. Sorry.
That is
I was just trying
I
to
can take
recollect the
like
name.
when you told it takes longer time, no, I thought it must be, but that is not very, we used it for this thing, but I say international society, they don't accept that as a
Yeah, diagnosis they accept, the diopsis they don't
Diopsis.
accept. Diagnosis is another ERG which is being used in the space. By the NASA, they use it in the space most of the time. So diagnosis ERG is good. And the one which you're using, Roland? Or
No, we have Metrovision, diagnosis, and Varies also. But after diagnosis, we are using only, was spoiled, we are using only that's like almost like gold standard diagnosis.
So one is you have to use the dark adaptation. It really takes time. The clinical ERG, the otherwise called as the diopsis, takes very less time to do the test, but it is not the same as the other diagnosis. It is not very accurate, but it still gives you some value, especially for.
If you ask the company people only, if you ask them 2-3 leading, then they will only tell this is actually not ERG, sir. Basically, that started for glaucoma, sir. Basically, pattern ERG to recognize early ganglion cell loss and all. Now they are.
So any other questions that it is not necessarily only the PGs have to ask. The others also can ask any questions, because we have the retinum people here and we have the glaucoma people here. EVA people are also here. I think they are still here. You want to ask anybody? Because they are all very silent actually.
Yeah, I know. Now, if you understood just the fulfilled ERG, the different types of ERG, origin of the waveform like AO and all that, somehow will end up writing for 10 marks and you will answer. And they don't fail you for not answering ERG. It's only to give you the gold medal, the extra marks, to differentiate you from other fellowship. That's where the thing. But it may so happen, like for example, because of the exam stress, you have not answered other thing well, like diabetic retinopathy. You answer ERG well, then examiner is sure, okay, this person is intelligent. Maybe because of tension, you would not have answered. They will definitely pass you. That's the tricky thing.
The Chandigarh people are using the ERG on a regular basis. Chandigarh, Arvind, the people are also here. Some.
We are, sir.
Dr. Tumar. Dr. Tumar.
Sorry.
You are also here, Dr. Tumar.
Yes, sir. We do, sir. In fact, Simar, who collaborates a lot with Purna Chandra, my colleague, and Dr. Diksha, we have two people who predominantly look at pediatric retina, and Simar has actually taken the lead in our department, and does that. Just want to take your opinion on the Retival, the handheld things, and all of that. Any experience with that? Do you think it for let's say younger kids, is it something that you would recommend? Do you do it, and what's your experience on that?
No, we had this all Retival and this thing diagnosis when they came to me, and we did a 6-month study where we did the ERG normals on that and this thing. Both are not at all comparable. My answer is straight away no, because it's not standardized one. So of course in future you never know, if you generate more and more data where ISAV starts accepting it as a standard. But as of now, if you look at the physiology of the retina, the way it functions, dark adaptation, it doesn't match their technology. So I would like to say strong no if they recommend this is a short-term ERG shortcut and all that. It's not for that. It's not meant for that. So, but of course, it can give something, some clue. For example, if you have a kid who is like 3-year-old, not cooperative for this thing, you want to understand at least something whether their depolarization which is happening or not. In those scenarios, it can help. But publishing in a reputed journals is difficult if you do a Retival. So if you can invest in the ERG, it's well and good. And obviously for many ganglion cell-based disorders, you can use Retival for that. But it is not a substitute for ERG. It's not an ERG. It's if you ask, it's a visual evoked response. EVR is what they call in their the book, what they call. It's never written as an ERG. They mentioned as EVR, a visual evoked response, VER. VER.
Thank you.
Thanks.
To you, sir. How often you really use your OCTA in your retinal practice? Do you feel that it becomes kind of a mandatory that we have to have an OCTA today in our clinical practice?
Basically, initially when the OCTA came to our hospital, we are not very much convincing about the OCTA because before that we are very much dependent on fluorescent angiography. But slowly we could understand that what is the differences of this FA and this thing, it is so fast, and we can do it like if the morning, if we are detecting one branch retinal vein occlusion and we are giving the injection in the afternoon, and evening you can do OCT angiography on the same day, but you cannot do fluorescent angiography on the same day. So that is the it is
So
fast.
you are saying that you have really a specific indications that OCTA is pretty useful than your FFA?
like in all cases, all macular cases, like whether it is CNBM, DME, or BRVO, or anything, any vascular lesion, it is essential, very much essential.
Right.
And nowadays we are really, our number of FA is gradually decreasing.
Okay.
Because of this this invention of this Octa.
Okay.
So this
Purnachandra,
no, so it's just a question that so now you have stopped doing the FFAs and gradually you are just proceeding towards Octa.
We have not stopped. We have Whitefield FFA also. We have the standard FFA also. We have not stopped it. We are doing it very certain indication, not otherwise. Like at the baseline angiography in case of diabetics, but for the follow-up or in all other cases, we are doing OCTA.
Purnachandra, one is for the vein occlusions. How useful is the ERG in your practice? Do you really do in vein occlusions for giving the anti-VEGFs? Excuse me, just use the mic. One of the other indications to do the ERG is to see in the CRVOs and the AMDs. How often you really use the ERG?
No, if given a choice and time is there, I would definitely like to do ERGs in this vein occlusion because again it has got a prognostic significance. There is something called red flash ERG what we do. In the Gansfield stimulus, instead of white light, we use a longer wavelength stimulus. So there are one or two articles to support which I also strongly agree. So they can better predict the ischemic changes or a conversion in CRVOs.
Right.
Okay, but we are just going by the clinical definitions, traditional ischemic, non-ischemic and all that. But if you do a red flash ERG, it will be very useful. But because of lack of time, obviously patient, the cost factor involved, we are not doing, but it will be really useful in all ischemic disorders, not only CRVO.
Yeah.
In diabetic retinopathy also, before you get a FFA changes and all that. So we know that, Sir, yes, they all agree, like FFA, CNP,
that is exactly the reason.
Obviously visible.
That is exactly the reason, especially in case of NPDR.
Yes, sir.
The prediction of the NPDR progression with the ERG seems to be much better as a prognostic, treatment factor. So I would just go with Dr. Unni and Dr. Mohit. If you are doing that, how often you do the ERG in these patients, and also in vein occlusions, and in wet AMD, how useful you feel the ERG. I'm actually excited about the ERG because before that we were not doing. Once we started doing, then we are just using it as one of the very interesting tools, and which predicts much earlier than your OCTs. Though it is definitely, yes, it is pretty expensive to do the test. Please.
So, I would like to give a very politically incorrect answer, which means that I like doing the ERG, but eventually we do it only when we need a publication or a presentation. So it is not easy to do. That's what I'm trying to say. There is a lot of effort in the technician's part, lot of effort.
I completely agree with you on that.
We have two machines, the Roland and see somehow if you do it in one machine, somehow the other machine doesn't give you comparable readings. So just to diagnose, see, he has told a very important point of a red flash, which is brilliant. But I would get the same amount of information from our ultra wide field imaging. So there are many ways to find the same thing. ERG is a very cumbersome, but for a person who's so mentally tuned to it like Purna, he can do it. I say he's brilliant at his work, so he can do it. I would also like this opportunity to just disagree with Dr. Boral, with his permission, about OCTA. And a message to all the postgraduates, OCTA is not dye-less angiography. OCTA is a totally set of new findings. You end up doing less dye-based angiography, not because it is a replacement, because it gives you different information from different points in the retina, depth resolved information. So for all the reasons we stopped doing angiography for CNVMs are not because of the dye, it's because the OCT got better. And we were able to diagnose using OCT. And then if we've done OCTA, it means that we're getting even better information from that rather than the dye-based. So the OCTA was not the death of the FFA. The OCT becoming better, the depth resolution getting better, the information from the OCT getting better, was it probably the depth of the fundus fluorescent angiography?
Yes, you have a multiple centers. I'm sure that you may be having different OCTs. I'm not sure about that, but after we started using the spectralis, can you just say that other OCTs, if you have, is it giving the similar kind of details, or is that something they can look at?
Again, I'm biased there. I use a spectralis.
Yeah.
Then I bought company X, and I didn't like it, so I sent it to a branch. Then I bought company Y. I didn't like it, sent it to another branch, and we bought spectralis again. So what I mean to say is, if you're used to the spectralis, you don't like changing it.
Absolutely.
And not that the others are bad, but you don't get used to the pictures and the quality as much as you like the spectralis. And I am a financial disclosure. I'm a KOL for spectralis.
Yeah. Sometimes once you really like that, then it becomes an obsession to use a spectralis. Everything else you feel that it's all useless, right? Any other people have any? You had something to ask, actually. Yeah.
No, I just asked, sir.
Okay. Any other comments from any of the presenters or others that?
I just wanted to add one point on ERG, this thing and all. In case if you're planning to invest in ERG, any ERG machine if you buy, it should have its own normative data. So that's your first time. Once you buy an ERG machine, generate its own normative data and compare it to its own results, because even if there is a micro, milli, nano volt difference, that could give a difference, because all the amplifier impedance, it cannot be same. As I rightly mentioned, when you do it on a different machine, it could be different. Okay, the earthing, room condition has to be perfect. It requires some time to build that. So it's not like you got the ERG machine, next day you order the patient and start doing it. Before you do it on the normal patient. Just try to understand the earthing condition of all that, all the noises, electrical noises. Be sure of it, then generate the normative data for all the age groups, except the pediatric less than 5 years, more than 5 years you can generate. Then start doing it on the patient. Okay, so now the companies like Diagnosis, they sell normative data for a higher price, but I don't agree. You need to generate normative data for Indian patient. Because of the melanin pigmentation and all, sometimes amplitude, there could be subtle difference, but in diseases which are very subtle, these differences could be significant. So that is something which I strongly advise in case if you are planning to invest on an ERG.
Okay. How many of you have octopus visual fields? Nobody. Okay. Okay, I have somebody supporting here. Okay. So octopus was the first visual fields to be introduced than the Humphreys. I'm not here to promote the octopus, but the data which you get is much more than what you get with your Humphrey visual fields. Though I was using Humphreys for 20 years, and the past 10 years I've been using, 12 years I've been using the octopus. It gives a lot of information, especially identifying the diffuse loss versus the localized loss, looking at the neurological deficits, looking at the optic toxicity changes. The octopus visual fields plays a very critical role. And assessing the progression with the serial analysis and the progression analysis, again the octopus gives you a lot of values. If you have some time, please go see both the machines, Humphreys and the octopus. And also when you have the refractive errors, how the HFA7 really helps with the lenses. So there's a lot of small practical things I wish you can go and see in the stalls are there. You see both the Humphreys and octopus machines, how the stimulus is being projected. So look at the octopus 600 machine, how the stimulus is being projected from the infinite source. So we'll understand things really very practically. So if there are not much of questions, I'm pre-closing the session by half an hour. Thank you all for being here with us to understand and learn things. I hope there are a lot of tips that you are carrying home today. Thank you all. The presenters, you did an excellent job, and I learned a lot of things in this session.
Yeah, all of us, I think we learned a lot.
So may I request the presenters, some of you are not there, to come to the stage so that we can have a picture. Photo session, please. And really like to thank Dr. Ashwati for your coordination, and you could pull in quite a good number of crowd. Thank you so much for your excellent coordination.
Thank you to the chairpersons and the speakers here. You've really enriched the postgraduates with topics both important for their exams and clinical experience. And a big shout out and thank you to the postgraduates for sitting through the entire day and making EyeShala a grand success. This was a big beginning for AIOC 2024, and there are many more days to come. See you soon. Before that, we'll get a picture with the chairpersons, and the postgraduates can join too. We can have a picture.
Sure. What I feel is those who were here, the PGs, should tell their colleagues to at least look at those recorded videos. I think there are a lot of information being passed on. I think it will be really useful for them.
Yes, sir.
Photographer is here.
Looking for, sir.
Yes, he's there.
You can take the video. Ashwati.
Ashwita. इसमें लेंगे क्या? Postgraduates can join for a picture too, because I think they are the real important, crucial part of EyeShala. This session is for you.
Whoever is the best performer in the postgraduates, from Narayan Natalaya, Pune Chandra will give one Rolex free.
They heard Rolex watch.
Rolex watch.
They're not looking at Rolex.
They prefer Rolex than Rolex.
So should we come in the front? Because
Yeah, please.
Sir, आप लोग बैठने में
Okay. And Dr. Onni will be giving one OCTA. I think we should sit down so that I can be seen.